things.
Hello.
He's now busy with the Facebook Live.
Hope you see the message.
So the other people who are assisting him, the event manager or whatever it is called, they are also not seeing.
Yeah, this is
It is not flashing. They are seeing the program right now, but program should be seen from the mobile. Is better when you are in front of the.
but I think it should be seen the messages.
Not saying it. Ashokan has joined. Hi Ashokan, good morning.
Now Vivek, Prakash Dilwania, Ashokan is muted.
No, Ashokan has just unmuted himself. Good morning, Ashokan.
Morning, morning,
Yeah.
Hi, how
How
are
are
you?
you?
morning.
What's going on?
Ashokan, you'll have to train Vivek Gupta to maintain the time.
And Cribier, myself as director. That was January 4, 5, 6 in Vigyan Bhavan in Delhi, and also one last day in the hotel. So that was a very extremely important conference, and I want to share the slides of that. Was just 5 minutes introduction. Who you have taken the just 5 minutes introductions about the conference. So this is the small video which I want to show you. This was actually a conference in Paris. I always love to show this. We did in 2009. Can you see, Dr. Tidwania? Can you see our screen? This is not visible to them. Yash? Can you hear us? Can you hear the video? This is Dr. Sigvard speaking along with Dr. Greg Stone. Can you see the screen?
aspirin and yes. So it takes so other things you are
So this was done. This was held in the Georges Pompidou Hospital in Paris with Dr. Cribier and many doctors from India presenting the case. This is Dr. Alan Cribier. The video is, I think, something wrong with the video. Okay, so skip this video now and go back to one slide presentation before you start the talk. Heart failure.
Dr. Vivekula,
Yeah.
you give you for the lecture of mine after Dr. Divania, there will be a continuation. Because in the program I see.
There is, yeah, that is the wrong, yeah, wrong sequence. Dr. Vivek Kumar will speak later on. Yes, I agree with that. Mr. Rishabh, can you stay with me? So, I think we can start the talk. We will show the later to the audience about the conferences जो कल आपने बनाया था वो कहाँ है इसमें स्लाइड बनाई थी ना कॉन्फ्रेंस के बारे में
किसमें कॉपी करी ये सर आईसीआर शेड्यूल पीपीटी नहीं डॉक्टर
So this is actually, can you see the slide? So Indo-European course on revascularization, we started in 2008 and I could get this brochure which was on their website and therefore I downloaded the first Indo-European course with Dr. Krivier and myself and other people. And there were, ICR meeting was in Vigyan Bhavan with 15 live transmissions at that time. So I always feel proud to say that the time of 2008 in India, we had CSI, we had NIC, we had Indian College of Cardiology, and there was no other major cardiology conference. India Live and other conferences they started later. So at that time, it was an idea with Dr. Krivier to start a conference here. And we at that time, we also had a TAVI symposium. International faculty included Dr. Krivier, Hélène Elshana, Martin Gillard, Dr. Bernard Chevalier from France, Dr. Pichard, and many others from USA. The first live transmission from all major cardiology center of India, Institute of Andaman and Nicobar Islands in Port Blair, in the March 1 and 2, that will be much better planned than this one. Actually, everything is fine except that we were, so this conference today, what we are going to show, will be having lectures from, the first will be heart failure session, and then that will be followed by coronary artery disease, mitral valve symposium session, coronary artery disease symposium, and that after that there will be aortic valve intervention, there will be coronary intervention, and then it will be validatory function. So it's a packed program with more than 25-30 lectures and some live inbox by Praveen Chandra from Medanta Hospital. He will be joining here. I think now we go on to the session, which will be a session on heart failure after the small introduction about this conference. And I have to introduce my very senior colleague, Dr. Prakash Didwania, who is from US, Indian origin, but he has a huge experience of having a, can you show Dr. Didwania now? Huge experience of heart failure, other clinical cardiology for almost 2 decades or 3 decades in various conferences. And I am very obliged to see that despite having almost 12 midnight in US, he's agreed to give a talk. It will be chaired by Dr. Vandana, who will be just joining in, Dr. Mukesh Goel, who will be talking about the heart failure surgical part, and many others. This conference is continuously on Facebook Live and YouTube Live. This is sort of a hybrid meeting with Zoom connectivity, and many people will join through the Zoom. We already have doctors early morning in December on Sunday, and the last Sunday of December, and people are a little more lazy than, of course, in fact, including myself. So we'll have a crowd. I'm quite sure that we'll have a crowd by the 11 a.m. or 10 or 11:30 with the coffee break. And so after my brief introduction, I request Dr. Dedwania to start his talk on heart failure. Heart failure is a very important and serious condition because it has got a mortality and morbidity associated. Number of patients of heart failure is increasing day by day. For the people on the Facebook Live who are not medical people, I would like to say it is not there is a huge difference between the cardiac arrest and the heart failure. Heart failure means there is a ejection fraction, which is preserved ejection fraction or a reduced ejection fraction, two types. The rest I will leave with Dr. Prakash Didwania to speak about this important topic. And this is, I want to tell you that this will be Facebook Live, and then recurring, it will be going to seen by many people, and will be also on Instagram Live. So the number of people in the hall does not matter, because it will be actually being seen by many people later on, and we'll have each lecture separately dedicated, will be on again on various social media, so that people can have a watch later on and learn, educate, learn, treat, and teach and treat. This is the motto of ICR. Thank you, Dr. M.K. Das. Once again, I request Dr. Prakash Jitwani, and then later on, I will introduce Dr. M.K. Das regarding his, because he has a huge credential to his credit. Okay, so we go on. I leave this place for Dr. Jitwani to start with the contemporary approach in heart failure 2024 and beyond. It's a very comprehensive topic he's going to talk about. Please go ahead, Dr. Prakash Didwania.
Thank you very much, Vivek. It's my pleasure to share my experience with heart failure, which I've been involved in various studies and using the heart failure approaches for the last 40 years. I'm director of heart failure program here at UCSF and professor of medicine. I think Vivek rightfully said that heart failure is a major public health problem. As a matter of fact, it's a public health emergency. It is expected that number of patients with heart failure at the present time is in excess of 70 million people that are living with heart failure, and this number will increase exponentially. In US alone, it's expected that there will be 46% increase in Americans that are living with heart failure in the next 5 years. What is very important is that heart failure is worse than many cancers. 50% of patients with heart failure, once they develop the symptoms, not treated.
Dr. Vandana Bagga, I may request you to be on the stage for the chairing this session. She's the Director, Health Services, Delhi government. Okay, Dr. Prakash, please go ahead, please.
Another important thing to keep in mind is that there is significant healthcare cost burden with heart failure. It is expected that this cost of heart failure care will increase by 60 to 70% throughout the world. In America alone, this is resulting to about $70 billion per year. Now, what is very important to keep in mind is that heart failure, once it ensues, it's a downhill path all the way. Once the heart failure is onset, and then the patient is hospitalized, each hospitalization, their prognosis is worse until such point that they get very, very advanced heart failure and eventually die if not properly taken care of. Now, let me say a few words about heart failure in South Asians or Indian. Burden of heart failure in South Asians is very high as well. Unfortunately, we don't have very good reliable data about the incidence and prevalence of heart failure in people in India, and these data are lacking, and much, much more needs to be done. Also, there is lack of standardization of the definition of heart failure in India. Based on the disease-specific estimate, prevalence of heart failure is in several millions, and it's constantly increasing. The reason heart failure is increasing is because there is higher prevalence of CAD amongst the population at large. More people with MI are living now because of successful primary angioplasty or post-MI care. Overall, people are living longer, so with increased life expectancy, we must keep in mind that heart failure is a disease of the elderly, and clearly, number of elderly people are increasing, and it was approximately 115 million people over 60 years of age in 2016, but I'm sure that number has gone up and is supposed to be in the tune of about 130, 140 million. Many people have hypertension that is recognized as a disease. More than 200 million people will have hypertension by the end of next year. Increased incidence of diabetes. We are all well aware of the tsunami of obesity and diabetes in India. Now let me just begin talking about where we were in heart failure, where we are and where we are going. Heart failure in the 80s was very poorly defined in terms of its pathophysiology, very high mortality, as I mentioned, worse than many cancers, and there was no well-defined therapy. So we were using predominantly bridge diuretic and vasodilators. Patients were hospitalized again and again, and their quality of life was quite compromised. Much has changed now. In the recent times, now we know that heart failure is a multi-system disorder. It's not just a mechanical problem with cardiac pump dysfunction leading to fatigue and poor exercise capacity, but it's also a renal problem because the activation of renin-angiotensin-aldosterone system, which causes sodium and water retention. It's a structural problem associated with LV dysfunction, LV dilatation and remodeling. It's also a vascular problem because heart failure is associated with dysfunction, and it's a endocrine problem. Actually, there is very few systemic disorders that we are aware of that causes so much neurohormonal perturbations as heart failure. Now, this is a synopsis of what heart failure is all about. Heart failure begins with some kind of myocardial injury or induction. It could be injury due to infarction. It could be pressure-induced left ventricular hypertrophy. It could be cardiotoxic drug. It could be cancer, etc. That causes changes in molecular biodynamics and altered cellular responses, which causes the process of LV remodeling and anatomical alterations as well. All of these then lead to cardiac dysfunction. It is the onset of this cardiac dysfunction that causes the circulatory perturbations, that is increased afterload, increased preload, and these physiological responses initially may be adaptive, but eventually they'll be maladaptive, and then this asymptomatic LV dysfunction leads to acute heart failure, pulmonary edema, etc. When we talk about the risk factor of heart failure, of course, we blame coronary artery disease, etc., but we must not forget that hypertension is the single most important etiology for heart failure in the population at large. Very important to keep in mind because if we properly treat hypertension, we can basically avoid failure. Diabetes is emerging, and of course, most diabetic patients have hypertension, which could then be related to the double whammy effect. And patients who have hypertension and diabetes are at high risk of having coronary heart disease, which also then will be responsible for LV dysfunction. In addition to that, we have emerging risk factors such as obesity, insulin resistance, metabolic syndrome, chronic kidney disease, which is present now if there's in 1/3 of the population, familial cardiomyopathy, viral cardiomyopathy, and of course, COVID-19 sequelae also can lead to cardiomyopathy and heart failure. Now, let me just show you a simplistic diagram that I put together more than 30 years ago, how hypertension leads to heart failure. On the one hand, causes pressure-induced left ventricular hypertrophy. On the other hand, as I mentioned earlier, most patients with hypertension will have multiple risk factors that increases the risk of acute MI, and these together can lead to the process of LV remodeling, subsequently leading to LV dilatation and dysfunction and congestive heart failure and the subsequent related sequelae. Now let me show you a very interesting diagram which should impress you. In patients with diabetes and hypertension, treatment of blood pressure a little bit more intensively as compared to the routine. In the UK-PDS trial, just 10 millimeter better reduction of blood pressure, systolic blood pressure, 154 in the control, 144 in the intervention arm, led to halving the risk of heart failure. The risk of heart failure, as you can see, was reduced by 56%, and so were other complications related to diabetes and hypertension. Now, we must also remember, as I mentioned to you, that heart failure is a disease of the elderly people, and quite often the elderly people have hypertension. So this is a trial of people above the age of 80 years. I want to emphasize that as Indian population is aging, more and more elderly people will be seen, and right now they are quite frequently ignored. They are not well taken care of. But in these elderly people, you can see the treatment, active treatment of high blood pressure was associated with more than 60% reduction in the death due to heart failure, which is very, very important to keep in mind. And we should not ignore treating elderly people's hypertension just because of their age, because it will prevent the subsequent development of fatal, non-fatal stroke and heart failure. Now let me come back to the pathophysiology of heart failure. This is a diagram from a lecture Gene Brownwell gave more than 30 years ago, the Shattuck lecture in 2000. What he emphasized was what I mentioned in the earlier slide. With myocardial injury, there is perturbations of cardiac function. This leads to some acutely adaptive changes, which is the activation of neurohormonal axis, adrenergic nervous system, renin-angiotensin aldosterone system, endothelin, and many others. Acutely, they are adaptive, they maintain circulation, and as such, they are called adaptive. However, if not properly treated and are not interrupted, they become maladaptive, and this maladaptive neurohormonal system is what causes the hypertrophy, remodeling, apoptosis, and subsequent vicious cycle of cardiac dysfunction. And our focus in the last 30 years has been to inhibit this maladaptive phenomenon, which is essentially blocking the neurohormonal activation, that is by ACE inhibitor, aldosterone inhibitors, beta blockers, etc. So this is a diagram I developed some years ago, emphasizing the various stages of heart failure that we described in the previous guidelines. Stage A, B, C, D. Let me just spend a moment. Stage A is when there is cardiovascular disease present, but there is no LV dysfunction. This is in the setting of hypertension, coronary artery disease, and this leads to LV hypertrophy and a subsequent myocardial infarction, which then can lead to stage B, which is LV remodeling dysfunction. This is when left ventricular is dysfunctional, and it is at this stage we should be interrupting this process by neurohormonal blockade for preventing further remodeling, and this is done very effectively by renin-angiotensin aldosterone blockade and sympathetic adrenergic system blockade by beta blockers. If we don't interrupt here, we will then have overt heart failure and then subsequently terminal stage of heart failure, which then perpetuates the whole problem. So this is very important. First of all, most important thing one can do is prevent heart failure altogether. And if you don't prevent it, treat it properly subsequently. So let us talk about what are the goals of therapy in patients with heart failure. Of course, first and foremost goal in any patient is to relieve the symptoms. This can be done by simple measures such as salt restriction, diuretics, and most newer drugs like SGLT2 inhibitor. The other goal should be slowing the disease progression. This can be done by neurohormonal blockade with ACE inhibitors, beta blockers, and also to some extent resynchronization therapy. Of course, as I mentioned, heart failure is associated with significant increased mortality, and this can be reduced by a number of therapies that are listed here. I will review with them very briefly, but we must keep in mind that one of the bases of reducing mortality is blocking the renin-angiotensin aldosterone system, beta blockade, and also more recently device therapy and isosorbide dinitrate. So I keep mentioning the activation of renin-angiotensin system and sympathetic adrenergic system because this is the system that is really involved in LV remodeling. You can see the activation of this system, which is due to the poor cardiac performance, leads to all of the cellular and structural changes such as LV remodeling, progressive LV dysfunction, and subsequent manifestation of symptoms and consequences of heart failure. And there are a variety of different processes that are involved, including fibrosis, apoptosis, hypertrophy, molecular alteration, and myotoxicity. And this leads to a variety of different changes, such as increase in preload, increase in afterload, sodium and water retention, and subsequently leading to all the symptoms of heart failure that you're so well familiar with. So I think clearly the main axis of therapy is RAS inhibitor, and we saw the benefit of in the SALT trial. There was a 23% risk reduction compared to those who were not on RAS inhibitor and were only on DIG diuretic. Subsequent, the beta blocker trial showed further 34% reduction on top of the RAS inhibition, and clearly we showed that in some patients, addition of ARB on top of other therapies was also beneficial. Now, let me briefly mention about the pivotal role of aldosterone. Although we block some of it by ACE inhibitor therapy, we must keep in mind that there is an aldosterone escape. This increased amount of aldosterone causes collagen deposition, fibrosis, and further worsening of LV remodeling. And it also at the same time causes salt and water retention, leading to edema and deprivation of potassium, leading to arrhythmias and subsequent increased risk of sudden cardiac death. We showed many years ago, more than 20 years ago now, that aldosterone antagonist therapy can not only reduce edema and other water retention, it also prevents the myocardial fibrosis and prevents sudden cardiac death. And this has been shown now that we can also treat patients early on with post-myocardial infarction. This is the emphasis trial that showed that patients post-myocardial infarction that were treated with eplerenone had about 37% reduction in the risk of heart failure or death from cardiovascular cause, and death from any cause was also favorably affected. Now, of course, we can treat these patients with the available drugs, angiotensin receptor blocker, ACE inhibitor, beta blocker, but still you can see that despite reductions, still 60% of the patients remain at risk of subsequent problems. And this is where the paradigm trial that was done with ARNI, neprilysin inhibition with ACE inhibition compared with ACE inhibitor was shown to be highly effective. Time does not permit for me to talk about the escape phenomenon, but in patients who are treated with ACE inhibitor, ARB and beta blocker, still there is much residual risk remaining. And clearly in this slide, you can see that neprilysin inhibition with valsartan, with Entresto, was associated with 20% reduction in the risk of hospitalization or death, which was highly, highly significant. It was shown that not only the death from any CV causes was reduced, but hospitalization was reduced equally by 21%. Now, the next drug that comes in mind and that has only been known to us in the last 5 years is the drugs called SGLT2 inhibitor. SGLT2 inhibitors were primarily investigated for treatment of diabetes, but we were surprised to find in the EMPEROR outcome trial that blocking the reabsorption of glucose by SGLT2 inhibitors, 90% is blocked. This was associated with significant benefit in preventing heart failure onset and subsequent hospitalization. Now, we must keep in mind that SGLT2 inhibitors not only block the reabsorption of SGLT2, not only block the reabsorption of glucose, but they also create the natriuresis, that is sodium excretion. So not only there is significant glycosuria, but there is also natriuresis. So I call SGLT2 inhibitors an optimal diuretic, if you will, that causes significant volume loss and decrease in weight and also energy loss. And there are multiple drugs that are available in this class. The first three drugs are EMPA, DAPA, and canagliflozin. They were investigated for diabetes, but I think they have a pivotal role in heart failure now. And this slide summarizes some of these trials. You can see here the results on the first trial, EMPEROR outcome trial, showing a significant 25% reduction in combined endpoint. Here is the DAPA HF trial. It shows again about 20-some odd percent reduction, 26% reduction here also in the combined endpoint of CV death, heart failure hospitalization, or visit to urgent care for heart failure. And this is a slide from the most recent trial that we have done with sotagliflozin, which is a SGLT1 and SGLT2 combined inhibitor. And this also shows a dramatic reduction in this patient with acute heart failure. And clearly, this is of high benefit. Now, what is surprising in the DAPA HF trial is that regardless of whether the patient had diabetes or not, there was benefit regardless of the presence of diabetes. So I think the benefit of SGLT2 inhibitors is not related to the presence of hyperglycemia or diabetes. It is direct effect on diuresis as well as probably on myocardial metabolism. So based on these trials and a very quick summary of what I provided to you, at the present time, we consider these as the 4 pillars of medical therapy for heart failure with reduced ejection fraction. As I mentioned, ACE inhibitor, ARB, and when needed, ARNI. That's the first line therapy for most patients. Beta blocker should be utilized in most patients, and mineralocorticoid receptor antagonists, and including the most recent data with finerenone, could be highly beneficial. And SGLT2 inhibitors now should be utilized in patients with both systolic as well as diastolic heart failure. And this is agreed upon in the European Society of Cardiology guidelines as well. Now, what is very important for the clinicians to keep in mind is that the benefits of this quadruple therapy is evident within 30 days of initiation. So think of heart failure as worse than many cancers. Which chemotherapy provides the benefit within 30 days to the patient? None that I'm aware of. On the contrary, these therapies for heart failure show reductions with anywhere between 25%, and if you use all of them, 58% reduction within 1 month of therapy. So clearly, if you're not treating your patient with all of that, you are really missing the boat. And this is very, very nicely emphasized that when you look at the patient with heart failure and look at their mortality as one with placebo on, and then add drugs such as ACE inhibitor, beta blockers, and have all 4 drugs of therapy, you can see that you can reduce their mortality by 61%, and so that there is now a hazard ratio of only 30.39. So very, very important to keep in mind. And this benefit is seen continuously throughout the follow-up period. And this provides a prolongation of life in heart failure patient by 6 years, which is phenomenal compared to any other disease such as cancer. So I think the last 2 or 3 slides I want to show you is that the patients with elderly patients, a patient with hypertension, they are now presenting to us with preserved ejection fraction heart failure, so-called in popular term as diastolic heart failure, because their LV systolic function is preserved, but they have significant difficulty in terms of their breathing, they retain fluid and other things. However, although time doesn't permit for me to discuss in detail, you must determine what is the phenotypic type of the patient with HFpEF, the so-called diastolic heart failure. Is it due to hypertension? Is it due to amyloid infiltration? Is it due to renal disease? Is it due to coronary artery disease? Is it due to metabolic syndrome or pulmonary hypertension? Because each subcategory will have a different kind of therapeutic approach. So I want to finish now by emphasizing the treatment of patients with preserved ejection fraction or so-called diastolic heart failure is primarily focused in the past on relieving symptoms and reducing congestion and preventing hospitalization. But now we have a class of drug that is highly effective in preventing rehospitalization as well as their subsequent mortality, and these are SGLT2 inhibitors. 2 drugs have been shown, DAPA and empagliflozin have been shown to provide such significant benefit. This is the trial Emperor Preserve that I was a PI for. In 6,000 patients, LV ejection fraction more than 40%. The primary outcome was composite of CV death or heart failure hospitalization, and significant benefit was seen. The other trial was delivered. This was with dapagliflozin against more than 6,000 patients, LVEF 40% or more, and this also shows substantial benefit. So at the present time, when we talk about management of patients with heart failure with preserved ejection fraction, of course, we give diuretics for fluid retention, but the main therapy should be with SGLT2 inhibitors. 2 drugs have directly shown evidence of benefit. These are dapagliflozin and empagliflozin, and certainly we should treat the underlying problems such as hypertension, infiltrative cardiomyopathy, etc. So I don't have time to go into the devices and cell transplantation. So I'd like to conclude by showing the state-of-art therapy for heart failure in 2025 and beyond. We should be looking at the various treatments that are available and should really be defining the heart failure patient as patients who are at very high risk of death and morbidity due to recurrent hospitalization and compromised quality of life. And clearly in patients who have heart failure with reduced ejection fraction, we should not be focusing just on diuretic, which many clinicians do. Diuretics only provide relief from congestive state and have no survival benefit, and they are a short-term patching phenomenon. In ACE intolerant patient, ARBs can be utilized, but ACE inhibitors or ARNI should be the basis therapy. The sacubitril valsartan, ARNI, or in various countries, different name, but we call it Entresto here, and very highly effective. And clearly, we must not forget the pivotal role of aldosterone antagonists as well as SGLT2 inhibitors. And in patients with heart failure with ejection fraction, in addition to the symptomatic relief, we should be treating all of them with SGLT2 inhibitors. Now, I want to end on a preventive note. That is the best strategy for heart failure is prevention by timely treatment of risk factor, particularly simple conditions such as hypertension and or better control of cardiometabolic dysfunction such as diabetes, CKD, and metabolic syndrome. So my suggestions for improving care of patients with heart failure in India is we need to develop and adopt uniform diagnostic criteria. We need to implement reliable surveillance programs such as heart failure registries, which I have tried on multiple occasions but have failed. Really, there are no very good registries that I'm aware of. We should also establish standardized protocol for both inpatient and outpatient care of heart failure patients and post-discharge follow-up, which is extremely crucial in our experience. Develop and adopt national practice guidelines for heart failure and implement primary and secondary prevention guidelines to treat simple diseases such as hypertension, diabetes, coronary artery disease, and treat patients with appropriate drug therapy. Future direction has many different venues, but I think time doesn't permit for me to get into it. So thank you very much for your attention.
Thank you, Dr. Prakash Jijwania, for a very comprehensive talk, and I would like you to stay back because we'll have some discussion after that. But Dr. M.K. Das is having a huge interest, and he has been speaking about heart failure all over the globe, including ASC and including ACC, and he is a past president of Cardiological Society of India. He is from Kolkata, having a huge academic interest and potential, and he has also organized Cardiological Society of India meetings earlier. He will be talking about basically the medicines, the role, especially the guideline-directed medical therapy in heart failure. Let me introduce our panelist and chairperson. I can see on Zoom Dr. Abdul Rashid Khan. He's our old friend, and he invited a couple of times to Karachi in Pakistan, and he's also one of the very senior and eminent cardiologists from Karachi. And he's sitting there. He wanted to come, but we couldn't go because of the visa issues. And but still, we have on Zoom him, Dr. Abdul Rashid Khan. And then sitting here on the chair is Dr. Vanda Bagga. She is the Director Health Services, Government of Delhi, and she's having a more than I think 5,000 doctors or 3,000 doctors working under her capacity in Delhi. And they'll all be part of this program, and few are on the Zoom, Facebook, and other things. So let me start with Dr. M.K. Das to start this protocol, and then we'll have a small few minutes of panel discussion after on the heart failure, and Dr. Mukesh Goel will be talking about the surgical part. Thank you, Dr. Das, to be there and waiting for some time, small delay, and I think you'll pardon me for that.
Thank you, Dr. Gupta, for arranging this conference online, and also to the organizers for giving me the opportunity to talk on this issue, that is the guideline-directed medical therapy for heart failure. There are fantastic presentations from Dr. Didwania on several occasions, and this one is one of them. And he has really put his points across the table that these are the methods by which you can follow the therapy for heart failure. But the issues of implementation is always haunting us, and that is the problem with the heart failure management. It has evolved significantly over a period of years. Various strategies have been formulated, and professional organizations have really worked hard for giving this kind of guidelines. They have definitely yielded results by not only reducing the recurrent hospitalization, which is an important marker of overall prognosis of heart failure, and it has also reduced the mortality, especially with the advent of novel therapeutic and devices. But that is not the total story with the GDMT and heart failure. The global burden is always very, very high, and we in this subcontinent, South Asia, actually we have got the heart failure incidence 10 years earlier than the Western counterparts. And that is why we'll have to give more emphasis on the guidelines. But the problem is definitely not only with the various implementation techniques, but also there is some definitional problem with the heart failure. We are more focusing on the ejection fraction, and we are classifying it and also giving the therapeutic agents according to the heart, what is called the ejection fraction over a period of time. And you can see the list of drugs that have really improved the ejection fraction over a period of time. And as Dr. Didwania has highlighted, that the list is going to be more and more. And the latest one is finerenone, tirzepatide, semaglutide, which are coming in a very big way in not only heart failure alone, but also heart failure with chronic renal disease and also some metabolic problems. And the whole paradigm shifted with the ARNI, as Dr. Didwania has told us, and there is 38% reduction in mortality. And you can see here that in all kinds of heart failure, definitely there is a reduction in not only the heart failure hospitalization, but also the mortality, overall mortality, as well as the non-cardiovascular mortality. SGLT2 inhibitors, they have changed the scenario, and also be more effective in heart failure with preserved ejection fraction or more ejection fraction rather than the EMPA and other SGLT2 inhibitors. And that's how we have come to the conclusion that the dapagliflozin is delivering an equitable care for patients with heart failure. There are different drugs, as I've been told, and I have already told that the more the ejection fraction is high, the SGLT2 inhibitors are more beneficial, and the other drugs are more beneficial with the less ejection fraction, less than 50%. And definitely with the declining benefit of ARNI, ARB, and BB with the higher ejection fraction. This is one of the factors which is inhibiting our implementation, that is the chronic renal disease, and they are possibly some of the other drugs which are non-interfering with the renal failure or the EGFR, like ivabradine and vericiguat, they can be quite handy. Another factor that is influencing the result of the guideline-directed medical therapy with the four foundational therapy is the presence of iron deficiency anemia. And this iron deficiency anemia is not exactly like the other kinds of iron deficiency anemia. Here, with the heart failure, something else is happening. That's why ferric maltose is giving better result with the injection form, and these are the treatments for this thing. And the ultimately we possibly thought that we got the GDMT and we are giving the four foundational therapies, and the add-on therapies like hydrogen nitrate, ICD-CRTD, ivabradine, digoxin, vericiguat could be given after the optimization of the guideline-directed medical therapy. And if they fail also, then we can think about the LV, AD, or heart transplantation. Of course, in acute episodes, we have to take care of them with the inotropes and the other drugs. And here I would like to mention about the omecamtiv mecarbil also, which also helps in the heart failure with reduced ejection fraction. Now, so far the device therapy is concerned, we have seen recently that the CRTD's implantation, especially in the elderly patients, has come down after after following the GDMT. So these are some of the evidences. So far, so good. But what is very surprising and very important to be known to all of us, that published prescription rate for heart failure reduced ejection fraction, and studies are showing that though beta blockers are being used, but these are not being used in old patients, and also same thing is happening with the ACE or RNE or MRA and evapradine, even after being informed as the guideline directed medical therapy is not being implemented. And that is not only applicable to India or Pakistan or Bangladesh or South Asian countries or other countries in Asia. It is well applicable to even the advanced countries. And these are some of the data which are showing that the implementation of the drugs are not being followed in most of the countries in India, and that is well applicable to the advanced countries like Japan, Sweden, and United States. You can see the various statistics over there. I'm not going into the detail of it. And what has been found as a sort of conclusion, I would like to say that patients without GDMT cohort had 29% increased risk of mortality, potential caused by some of the drugs like RNase inhibitors, etc. Potential caused by some of the drugs like RNase inhibitors, etc. And there were also the therapeutic inertia. And even though we are highlighting GDMT in various lectures and communications, but they are not being followed by the physicians, and that should be taken care of. So what should we do? There are various methods, like we can take the help of traditional sequencing, sequential, early dose escalation, rapid sequencing, simultaneous initiation, prioritizing enabling therapies, sequencing trials, and polypill. Polypill is another good sort of methodology or method by which we can reduce the lack of implementation, and we can give the confidence to the patients that with a single drug or just one or two drugs, we can give the equal benefits. Now, for achieving these, but there are so many other quality control improvement methods, but out of this, possibly electronically recorded therapeutic measures is very, very important, and that can be possible by using the digital technology with the different methods like remote monitoring, then EHR enabled identification and all. And I'm not going into the detail of it, but telemedicine is coming in a very big way, and it still requires validation for total implementation, but this will help in the long run. EHR based, I have already said that prompt heart failure has shown some demonstrable improvement in the primary outcome of an increase in the number of GDMT classes prescribed at 30 days and GDMT dose with targeted integrated and these cohorts can give some specific groups who can be treated with the specific kinds of drugs. Thereby, you can reduce the pill burden and we can get the benefits of the patients. These are some of the additional methods which Dr. Didwania actually skipped, but these are coming in the futuristic way, like Bioventrix, which remodel the dilated heart, then Barostim Neo, which which are not the patients which are not candidates for CRT, etc. Then they can be implemented. HeartMate and cardiac contractility modulation device is also coming in a very big way. Artificial intelligence can give rise to new phenotype by continuous feedback mechanism, and that's how we can improve the GTMT and thereby improve the ultimately mortality and morbidity. So to give you the carry home message, individualizing strategies for attenuating the burden of comorbidities and heart failure related rehospitalization is the cornerstone in achieving the therapeutic goal for heart failure, which is reducing the mortality and also morbidity. The predictors for heart failure rehospitalization to be evaluated and taken care of in an appropriate time: therapeutic inertia, lack of adherence to the GDMT, patient's inertia, and barriers for implementing the GDMT should be taken care of. A coherent statistical model for constructing risk assessment should be attempted, and focus for our own population, Asian heart failure registry, over a prolonged period of time should be taken up, and technological advancement like remote monitoring systems, machine learning, AI, and artificial intelligence, and application of therapeutic digital tools may prove to be the future of the holistic heart failure management. Thank you very much.
I think a very important, comprehensive, educative talk by Dr. M.K. Das, who is also the president of the Asian Heart Federation. So we are very proud of him. And now, before we go into panel discussion, Dr. Abdul Rashid Khan is there. We'll have a very quick 5 minutes or 7 minutes talk by our surgical colleague, Dr. Mukesh Goel. He will just touch upon the surgical part of the heart failure, surgical treatment. Let's see what he's going to talk about. And then Dr. Prakash Tidwani, I know it's very late, more than midnight. So yeah, so I would request you if you can just, stay back. Dr. Mukesh Goel, please go ahead with your talk. Then we'll have a small panel discussion. Can you come just here? Your slides are there. Dr. Can we have the slides of Dr. Mukesh Goel? Dr. Mukesh Goel is a senior consultant surgeon in our hospital in Apollo, and his work area is bypass surgery.
Thank you, Dr. Vivek, for giving this opportunity to present my thoughts and my work in front of you. So, Dr. Das, he has just touched upon what should be the optimal medical management and how it improves survival and quality of life in patients who are suffering from end-stage heart failure. So heart failure, as we know that it is just inability of the heart to supply the need of the body. I'll just skip because we have go through much of the medical management and heart failure. So despite the optical management and very encouraging results of various agents for improving heart failure results, there is still a 50% mortality at end of 5 years in patients who are suffering with end-stage heart failure. So what is there beyond these drugs? How we can help these patients? So the further advanced treatment for patients who are now no more doing okay with medical management is left ventricular assist device, or commonly called LVAD, and heart transplant. So when you should, as a physician, refer to your patient to a heart failure specialist. So as you know that with the medical management in consultation with the cardiologist and heart failure specialist, you can manage your patients, you can adjust their doses. But when the symptoms are not improving or getting worse, despite your maximal tolerated medical dosage, and ejection fraction is less than 35%, and either because of the treatment or because of the worsening heart failure, the other organ functions is deteriorating, like renal function or hepatic function. So these patients should be referred for advanced treatment. So when a patient will require a definite transplant or a LVAD is when the patient is NYHA 3 or 4 despite guideline directed medical therapy. He is intolerant or refractory to the agents of medical therapy like ACE inhibitors, ARBs, beta blockers or ARNI because of the blood pressure or heart rate issues or symptomatic issues, that if you try to increase the dose, the patient becomes too much more symptomatic rather than improving. And the daily diuretic dose is more than 1.5 milligram per kg per day. So diuretic, mind you, is not a part of guideline directed medical therapy. The diuretics, they do not improve survival, or they are only symptomatic treatment in patients who are suffering with symptoms of congestion. So when the diuretic dose exceeds 1.5 milligram per kg per day, that is a basically red sign. Then the patient is developing renal or hepatic dysfunction. The patient has got a congestive heart failure related hospital admission within last 6 months. So these patients should be considered for transplant or LVAD, whatever be the indication. So mind you, despite being the modern LVADs and everything available, transplant is still the gold standard. But however, every patient cannot undergo a transplant because there are a whole lot of contraindication to transplant. And how do we match donor with recipients? First of all, we match ABO blood group. Like blood transfusion, we match the donor A with A, B with B, and AB with AB. However, like blood transfusion, O is a universal donor and AB is a universal recipient. Then the body weight between the donor and the recipient should be within 20%. This is just a few pictures of a transplant, how it is conducted. This is a heart which is being now retrieved from the donor's body. Sometime we have to transport heart with a charter flight because the ischemic time which is available for transporting a heart is very less. So this is we transported from Mumbai to Delhi. So we had to hire a charter for this, and it's a like great logistic and arrangement we have to make. And on the right side, you can see that this is a coordinator who is on phone. He's already requesting for a green corridor at Delhi airport to Apollo Hospital. And along with him is the anesthetist. He's telling the recipient team in Apollo OT that we are now entered into the aircraft and you can start the recipient operation. So this is a heart which is being taken out from the recipient, the diseased and dilated. You can see the size of the heart, too much diseased and dilated. It is lying outside the excised heart from the recipient. It's a donor heart being lowered into the body. And this is how we connect the donor heart to the recipient body. And this is on the left, you can see that how it looks like once the heart has been taken out. On the posterior most is the cuff of the left atrium. Then stump of superior vena cava, inferior vena cava, aorta and pulmonary artery. And these are 5 anastomoses through which we connect to the donor heart to the recipient body. This is a picture of a 5-year-old boy we transplanted 4 years back. He is still date the youngest transplant recipient in Asia. He was 5 months old. Still this landmark holds true. And this is his the same boy on follow-up. Now he is 3-year-old and thriving well. The first transplant we did at Apollo Hospital, the patient was sent home after 10 days. This is another 2-year-old baby. I will come to it later also when I will be discussing LVADs and biventricular assist devices or total artificial heart. So she was on, for 4 months, she was on Berlin heart or a biventricular assist device, and then we transplanted her. And this is, she's going home, and her mother on the right side sent a picture playing for 3 months back. The another two patients we going home after transplant, recent one. The post-operative management after heart transplant is standard like liver or kidney transplant. There is no difference. These are on lifelong immunosuppressant, tacrolimus, mycophenolate, and prednisolone for few months. Surveillance biopsy is done in the first year to know if there is any rejection happening or not, so that we can adjust the dosage. Nowadays, we can do sometime endomyocardial biopsy, and sometime we can do a blood test, simple blood test, which can tell us about the status of the rejection, and that is called cell-free donor-derived DNA. But there are limitations to heart transplant, like you know that heart can only be retrieved from a suitable brain dead donor whose family has agreed for the donation. And then there are logistic issues sometime. Last week what happened that there was a donor at Jodhpur, and the family wanted retrieval to be done and the body to be handed over at by 6 a.m. And we got a call at 12 a.m. in the night, and that this donor is available. So though we had the recipient, but there are no nighttime landing facility available at Jodhpur airport. So that heart and lung both got wasted because of the logistic issue. So this is one logistic nightmare especially in Indian setting. And advanced age patients are obviously not suitable for heart transplant, high pulmonary vascular resistance, other comorbidities like that. So what are the options for these patients who are not fit for heart transplant is LV assist devices. So the rationale behind using LV assist devices, this was published in New England Journal of Medicine in 2001, where the difference of a patient on LVAD versus on medical management. So there is a huge difference in the survival at 2 years of follow-up. So this established LVAD as a legitimate therapy for patients who are not for heart transplant, but who are compared to medical therapy. So these devices, they have improved and changed over the years. This was on the left is the first LVAD which was available. It had to be kept outside of the body with the cannula connection going through the body. Then in the middle, it was a HeartMate 2 device, where it was totally implantable with only a cable coming out of the skin for connecting to the drive line. And it has further improved. On the right, it is a HeartMate 3, which is the latest device available. So this is how LVAD looks, that it is a device which is connected to the left ventricle inside the pericardial cavity. Then there is a which is drawing blood from the left ventricle. Then there is a graft which is connected to the left ventricle to the aorta, so that this device, it draws blood from the left ventricle and pumps it into the aorta. So it has taken over the work of the left ventricle. It can give up to 8 to 10 liters of flow per minute as per the requirement of the patient. And so there is a drive line which comes from the patient's skin in the abdomen, which is connected to the console, and there are 2 battery packs. So purpose of LVAD therapy is bridge to transplant. That is, the patient who are otherwise fit for transplant and they are waiting for transplant, but they are too sick, because it might take 3 months, 6 months, or even a year or 2 years for a suitable heart to become available. And when we think that this patient is not too sick to survive for that period, so we can put those patients on LVAD and then later on transplant them. This is called bridge to transplant. And then destination therapy, when we know that the patients are not suitable for transplant, and LVADs are given as a definitive lifelong therapy. But because this LVAD, they only help the left ventricle, so the patient has to have a good right heart function for this to work properly, and the patient should not be too frail. So that's why any patient we decide to put an LVAD, we very diligently study the right heart parameters, so that the right heart can take the load of the left ventricle. Because the right heart becomes the functioning ventricle. The left ventricle becomes a simple conduit for blood to the left ventricular assist device. Then timing of LVAD is very important, that the patient should not be too sick. It is like buying a banana. If you buy a banana like at number 6, when the bananas are totally ripe, so you will hardly be able to eat at home because next day they will be rotten. So you will like that banana which are at the stage of 4, so that in next 3-4 days you can consume one by one easily. So that's why these LVAD patients should be referred well in time before they become they have irreversible liver or kidney function or some infection or any other problem. So the LVADs, more than 30,000 LVADs have been implanted worldwide in last 10 years, and there is good long-term survival with LVAD. And a 3-year survival on LVAD is now approaching that of a heart transplant, near 80%. Versus medical therapy, the comparable patients on LVAD and medical therapy, there is a difference at 2 years, 3-year survival. 2-year survival is 28% versus 80% with HeartMate 3. So you can see the difference, a huge difference. 79% patients on LVAD and 49% on the comparable stage of the patient NYHA class who were on medical therapy. The post-operative complication rate is very less, hardly 1% pump thrombosis rate per annum. So this is a patient we transplanted with, we implanted a LVAD last year. It's almost completing 1 year. After 1 month, he is going back to his country. This is how the post-operative X-ray looks like. So this is the device which is connected to the left ventricle, and you can see a cannula which is going towards the LV and looking towards the mitral valve. This another patient, he was on LVAD for 3 years, and the same patient I showed you a picture earlier after the heart transplant. So after 3 years he got a heart and we transplanted him. So this is how transplant this LVAD looks like. So the LVAD is totally inside the body, chest cavity, and there is a small drive line which comes out of the body, and this is like under dressing, and this is a small battery pack he has to carry. The patient can take shower, anything, do exercise, do running, jogging, everything. These LVADs are so good. So I will come to what are the options in small children where these LVADs cannot be implanted. So this was a 2-year-old girl who came to us very sick in chronic congestive heart failure with cardiogenic shock, and she did not improve despite 1 month of ventilation and inotrope, and she developed secondary renal and hepatic dysfunction. So we implanted her with this Berlin heart. So you can see these 4 big cannulas which are going inside the body because it's a small 2-year-old girl. And I'll show you the. So this is the right heart pump and this is the left heart pump. And right heart is taking blood out from the right atrium and giving to the pulmonary artery. And the left heart pump is taking blood from the left ventricle and giving it to the aorta. So this is a basically biventricular assist device or total artificial heart. The only kind of a case in India till date, and we kept this patient for 4 months on this biventricular assist device, and then we transplanted her. So while on the BiVAD, she was being taken out of the ICU for a stroll and fresh air. And this is on the right after transplant. So I will skip on temporary VADs in interest of time. And soon we are there is a work going on with the wireless charging of LVAD, so there will not be any drive line which is coming out of the skin, and there will be a fully implantable VAD which will totally be inside the heart and nothing in the pericardial cavity. But the challenges with the LVAD therapies are awareness and acceptance and cost, because this HeartMate 3, it costs something around like 1 crore in total, the device cost and the surgical management cost. And every heart failure hospitalization increases the patient risk of death. So with every hospitalization, the survival will come down. So we should not think that we have medically managed this patient and they will be all right. They just suddenly die at home. So heart failure requires a multidisciplinary approach depending on the patient's symptom and survival. And I will appeal for organ donation, that spread the awareness about organ donation. It's one organ donor saves 8 lives. Thank you very much for your kind attention.
Thank you, Dr. Goel, Mukesh, very nice presentation. May I introduce Dr. Mansoor Ahmad, who has also joined. Can we see that Zoom here? He's also from Pakistan and Karachi, and very eminent figure, and he has been in academic institute, and he's also a part of the panel now. So, Dr. Prakash Jidwani, I know that I'm doing a little injustice to you. We have a friend, Dr. Vivek Kumar, who will talk about the valves and heart failure. Very quickly, 5 minutes, because he has to go, otherwise we could have kept him in the next session. So Vivek, please come and otherwise he was supposed to speak on complete valve interventions, but I have requested him in the interest of the actually American people who have to sleep because they're already 1 a.m. there, where he's sitting. So I just want him, and then we want actually 2 minutes of some discussion on the heart failure subject. So, okay, please, Vivek, please go ahead with your presentation, very brief, whatever you want to speak on this issue. He's our colleague in Apollo Hospital and senior cardiologist and doing a lot of work other than angioplasties. He's also doing, we all together doing some TAVI and also structural heart and pacemakers and all.
Very good morning to everybody. Thank you so much, Dr. Vivek Gupta, sir, and he's been very kind enough to adjust me in this slot. And without wasting any time, let me proceed to my talk, which is on heart valves and treatment that we could expect in 2025. Can you play my slides, please? It's Vivek Gupta. Can you? So definitely, we have already gone through thoughts on medical management and the most advanced, that is replacing the heart or replacing it with an artificial heart in form of LVAD. This is my talk. Thank you. Okay. So we are now at the end of 2024. For heart valves and heart interventions, it has been a great year, no doubt. We have done some great work, new things are happening, and what we can look forward in 2025. And obviously, it's going to start from where we had begun. So what we are going to see in near future is that we are seeing aging India, where people will be older and people will be having comorbidities in form of multiple valvular disease, CAD, CKD, liver failure, CVA, and cancers. And these patients will require advanced cardiac care, and a very challenging aspects would be there because a lot of these patients would not be a good candidate for open heart surgery. So obviously, we have to think out of box and think about new innovations and making it practical in our daily practice. So these are the valves that we are concerned of. So we know that we have 4 valves in the heart: aortic valve, mitral valve, tricuspid valve, and pulmonary valve. And till about 5-10 years back, I'll say 15-20 years back, the only option for these patients have been going for a open heart surgery, undergoing a valve repair or a mitral replacement. But as I said, that with aging population, challenges are there. A lot of these patients may not be good candidates for valve surgery in form of open heart surgery. So these are the unmet needs in cardiac interventions. And to large extent today, at the end of 2024, we can say that we have really accomplished a lot of interventions and possibilities have been made that these patients could be treated. Like for example, this patient, 68-year-old male having severe symptoms of aortic stenosis and being very frail, he was not a good candidate for open heart surgery. So mic is not working, sorry. Yeah. Hello. So if we don't treat these patients, he is not going to survive more than 2 years. So Surgery, if you ask him, the mortality in such patients could be as high as more than 10%. We say these patients to be very sick for going for open heart surgery. What we can do for such patients, we can offer them a TAVI, that is transcatheter valve implantation. But before that, a lot of we have literature there, evidence there that in normal patients also who are more than 65 years old, we can offer them a transcatheter valve intervention, whether the patient is risk for surgery or not. For younger patients less than 65 years, still surgical valve implantation, if the patient is not a high-risk patient for open heart surgery, is a good option. But for patients who are more than 65 years or above or having multiple risk factors, we can ideally offer them a valve intervention in form of a transcatheter valve intervention. And this is what we did in this patient. So you can see this is the calcified valve. We took a femoral artery access. We had a Perclose device inside. We crossed the valve through this thermo wire, and then we proceeded to the valve implantation. And this was the evolute valve in this patient, and we could achieve a good result. And the patient was shifted to CCU for a day, and the next day the patient was fit enough to go home. And you can see the gradients improving. So one of the most common cause of heart failure symptoms is valve disease. And that's why if you treat these patients, the valve stenosis or regurgitation is treated, these patients improve very well. And similarly, we had another patient, a 67-year-old female patient, having calcified aorta, and such patients are not good for open heart surgery, and she underwent TAVI in form of with evolute valve, and you can see that the gradients are normal. So this is the patient, one of the earliest patient done, and within 24 hours, this patient could be good enough to go home. So we are now thinking about day-care TAVIs and things like happening. So definitely it could be a possibility in 2025 that we do an intervention in the morning and the patient is fit enough to go the next day, and it is very much possible. So not going to other cases, I'll just take you to some other aspects that apart from doing open heart surgery and in alternative to doing open heart surgery, going for valve intervention through a transcatheter valve intervention form, there could be possibilities. If you see in current scenario, as I said, that most of the patients who are elderly, we can offer them a TAVI, but younger patients and other issues like aortic regurgitation, still we have to lot of work going on. But sooner in aortic regurgitation, we are now having newer valves. So in such patients also, we can offer them a transcatheter valve implantation. This was another case. It was during my fellowship in Cleveland Clinic. So this patient had a previously implanted aortic valve, a bioprosthetic aortic valve that got degenerated, and TAVI was done in this patient. And this patient also required an angioplasty at the same setting. So it's not that if somebody is having a coronary artery disease and a valve disease, we cannot do valve intervention. We can do an angioplasty before or after the procedure, and as well as we can put a valve in these patients. So this was the case here, beautifully done and good result. So now coming to heart valves, which is most complex and is associated with a lot of heart failure patients, the mitral valve. So a lot of time these valves may be leaky, and we have data that if we change this valve, like for example in this patient, she had a previous mitral valve, bioprosthetic valve implanted, and we did a transcatheter mitral valve replacement in this patient with a very beautiful result. And we have to go transaptly through the interatrial septum into the left atrium. And this is how you implant we call this procedure a transcatheter mitral valve replacement. Now we have patient, this is the 3D echo before, and this is how the valve looked before, but if you see later on, the valve improved very well. Now we'll be having such patients. You can see this is a mitral valve, which is the PML is prolapsing, and the patient is having severe aortic mitral regurgitation. And this is a 94-year-old male. Can you offer this patient a open heart surgery? Not at all. And it will be very risky to offer such patients because they may be having multiple issues. But what we can offer these patients is going for what we call transcatheter end-to-end repair of leaflets. And this is what we call a mitral clip procedure. And here what we do is that we clip the mitral leaflets so that the regurgitant jet is treated, and a lot of heart failure patients, they die not because of the pump failure, they die because of the progressive MR happening and continuous overload that the LV is facing every day, and ultimately the patient developed end-stage heart failure and they die because of low output state. So in such patients, we have data that if we clip the mitral leaflets and correct the mitral regurgitation, we can treat this patient. And so this is how the clip looks in the fluoroscopy. And in this patient, 3 clips were used for repair of mitral regurgitation. Now, there are scenarios, we do BMV. So they are the most earliest structural heart intervention, and still mitral stenosis patient, if they are even high risk, we can try for a BMV to treat and reduce that gradient. And this is very much a very useful procedure. Now talking about tricuspid valves. So a lot of patients may be having a tricuspid regurgitation, and we may not be offering any surgical interventions for such patients because a lot of time they may be having liver dysfunction, low output state leading to cardiorenal syndrome. But in such patients also we can put a what we call a trick valve. So this is a valve which is implanted, it's a bicaval valve. So we put 2 valves, one in the SVC-RA junction and another valve we put at the RA-IVC junction. So what it does is that it prevents the regurgitation of the tricuspid flow into the SVC and IVC, and over the time there is a positive remodeling in the RA-RV, and such patients improve symptomatically. So this was about tricuspid valve repair. So scenarios, future is very, very hopeful. There is a very much a possibility that most of the valves, including the pulmonary valve, whatever may the etiology or pathology going on, we can treat these patients with a transcatheter valvular interventions. But yes, one size doesn't fit all. We have to choose our patients. So the take-home message is that aging population brings in more and more patients with degenerative heart valve disease. Surgical techniques in form of MICS, robotic surgeries are evolving, but transcatheter valve intervention has become a boon. The transcatheter valve intervention is almost matching up to the unmet need of high-risk patients of valvular heart disease, but in future, maybe a routine valvular disease could be treated with a good result with a transcatheter procedure. But yes, carefully selecting the most appropriate patient for the most appropriate procedure is the key. Future evolutions are going on to tackle other complex scenarios. All I can say, future is bright, but today cost is a major limitation. This is myself at Cleveland Clinic. So I tell you briefly about the history of this building. This is a very historical building. The first angiography happened in this very building, and I had a privilege to be there. Thank you so much. Thank you so much to the organizers. Thank you, Dr. Vedupta sir, for this opportunity. Thank you so much.
Thank you, Vivek. Mine, same name. For a good talk, and you stay back on the panel. So we'll have a 5 minutes panel discussion. Very important. You see, sometimes people feel that panel discussion is not important. I personally feel that panel discussion, whatever you have been summarized, can be summarized to the. So may I invite Dr. Mansoor Ahmad from Pakistan to speak a few words about heart failure condition in Pakistan and how you are treating there, because sometimes we don't get major information from Pakistan. So it is good that you were all part of together before 1947. So I still feel that you are a younger brother, country-wise, but of course you are a senior colleague of mine from Karachi. So please introduce yourself quickly and then talk about this heart failure session a little yourself. Dr. Mansoor. You have to unmute yourself, yeah.
Okay, it's wonderful to see you again. I remember you being in Karachi with us for a while and myself meeting you in Delhi at one time. And it's wonderful to be here. Now, heart failure, as has been mentioned earlier, is probably going to be, is already a very big issue and is going to continue to grow. as our populations grow. And I think we are living in very good time as compared to my training days when there was hardly any treatment known other than digitalis and diuretics. And today we have got wonderful drugs with prolonged life. And what I see and what I have learned from this talk today, that heart failure management.
Sorry, there is some change in the system. I want them to be on the.
Obese, and that's we all know that is one of the important risk factor for heart failure. So, what about the newer drugs, GLP-1, agonist, the semaglutide, and what is his opinion? So, I don't think it's available now. It's already late in USA.
Okay.
Maybe.
May I have a comment from Dr. Vanda Bagga, who is there, is a Director Health Services in Delhi. She has been a panel since the beginning of the session. And after that, I will have Dr. M.K. Das last comment to close the session. Dr. Vanda Bagga, please go ahead with your whatever comments you want to say about the.
Thank you, Dr. Vivek, and a very good morning to all the esteemed faculty, international as well as national, and all the participants present here. In 2 minutes, I have to summarize. So, main key points that I take home are: one is the risk factors that Dr. Ashokan has just mentioned, identifying the risk factors, the accessibility, the preventive and promotive aspect, that is very important, and the protocols, SOPs, and the operational guidelines. So these are the factors that we need to address, and most of these we are addressing. So we are having national programs to address all these aspects in a very systematic, organized way. So one is the national program for non-communicable diseases, in which we know that more than 32% of the mortality is due to non-communicable diseases, and out of which 63% is because of the cardiovascular disease. And as per the sustainable goals, our goal is to reduce this premature mortality by 1/3 by the year 2030. So we are coming up with the national program for non-communicable disease as well as the national program for healthcare of elderlies, that is going to address the issues of the elderly, the how to catch them. But a very important aspect is the accessibility. So the healthcare reaches to the masses. Preventive aspect and promotive aspect has to be taken care of. That brings us to the very other extreme of the thing, in which we address not only the at-risk population from the elderly group, but also from other groups. So one is the we have switched over from opportunistic outreach screening to the population-based screening, in which all the population above 30 years needs to be screened, and that is being done through the workers, including ASHA workers and ANM. So ASHA, as we know, is the initiative of India that is accredited social health activists. So they do the line listing of all the population. They have the listing, and they have the listing of more than 30 years population, and they have been told how to do the screening. After the screening, again, if they know how to refer the patients, after the patient is referred, then what are the high risk groups? They have to follow a uniform protocol. So we have SOPs, including SOPs for hypertensive disorders of pregnancy, which has been a state initiative. Again, we go back from maternal health to catching them young by changing their healthcare behavior. So that there comes the adolescent health as well as our school health programs. So I can go on and on, but due to the lack of time, I don't think I can address more. But my most important request to all of these are that we wish to work in a team manner, in which all the stakeholders need to have a proactive involvement. we need to upgrade our protocols, SOPs, procedures, operational guidelines as per the latest guidelines. We need to have access to the latest technological advancement, and the private partners are very much part of our team. All the guidelines, the SOPs that we formulate always have the experts from all the sectors. But now I would like to extend that to the international faculty, being a part of our government health programs as well. So thank you so much, Dr. Vivek.
Thank you, Dr. Vandana Bagga, for giving a really important comment and requirement, the need of the hour. Uh, I just wanted to thank Vivek and Mukesh for giving the LVAD and other issues of TAVI and other things. May I have the quick closing remark from Dr. M.K. Das? And before that, I would like to request Dr. Mansoor Ahmed and Dr. Abdul Rashid Khan to please, we'll have a coffee break after this, but we would like you to be part of the next session also, which will be on a live lecture from Dr. Rohan Jaisinghe from Australia, and then followed by the talk, on-site talk. So if Dr. Shokan and Dr. M. K. Das can also stay in that session, I'll be very much obliged. So Dr. M. K. Das, your closing comments on heart failure. Please unmute him. Yes. Okay.
Yeah, I think we had enough discussion, and definitely we are going in the right direction. And prevention is always better. A stitch in time saves nine, as is the usual proverb, and we should follow that. Having said all this, some of the risk factors are very, very important. Cardio, renal, metabolic, or CRM or CMR, whatever you call it, is a very, very big issue. Obesity is very big issue, and air pollution is another important issue, which is taking a toll on the not only coronary disease but also on heart failure. And from Cardiological Society of India, we are working on the primordial and primary prevention of the cardiac diseases in school children, and also we are training the children with the help of the teachers, so that we can take care of the stage A or stage B diseases right from the school level. And obesity, as Dr. Ashokon was asking, is very, very important issue. I would comment one point that in some of the patients of heart failure with the reduced ejection fraction, there can be an element of obstructive sleep apnea disorder. And we have found that after treating with the GDMT also, their session, and all the panelists and speakers should be congratulated for their beautiful presentations.
Yeah, Doctor, we have to just give the memento, and your memento, I have to really courier to Kolkata and also to Pakistan. Just stay for a while. So we close this session now for the coffee break. And thank you, Dr. Mansoor and Dr. Das, to stay back. But I will request Dr. Mansoor Ahmed and Dr. Abdul Rashid Khan and Dr. Ashokan to come back after 15 or 20 minutes after the coffee break to join the next session. You have the scientific program with you. Thank you. निकल रहे हो? So we have the coffee outside on the first floor. So all the people who are here may quickly go there, and within 50, what is the time now? 11:53. We are already late by half an hour. So we'll start exactly at 12:10. 12:10 we'll start back, and Dr. Vanita Arora is here, so it's nice to. So we'll have starting the next session at 12:10, and a small delay about 20 minutes is already there. So we'll be happy to have a quick coffee. Myself going there, and then we'll come back quickly.
Recording stopped. Hello, 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 hello.
Hello. Hello, one cheek. Hello. Hello, one cheek. Hello. Hello. Hello, one cheek. Hello. 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 Hello, one cheek. Hello, one cheek. Hello. Hello, one cheek. Hello. Hello, one cheek. Hello. Hello, one cheek. Hello. Hello, one cheek. पेन ड्राइव पे है ना, तो पेन ड्राइव से कॉपी कैसे देंगे? हम तो लगा रखा है पेन ड्राइव, कॉपी नहीं हो रहा आपका ये इसमें। ये तो तुमने इतना छोटा कर रखा, बड़ा ही नहीं करवा रहे हो। चलो कोई बात नहीं। ये फिलर साला है ना, ये फिलर तो अपने कॉपी कर लीजिए। या अभी ये सारे जो है कॉपी कैसे करोगे? हाँ करोगे, चलाते हो बीच बीच में। तो कुछ जूम पे जुड़ गए क्या वो?
टीवी में जूम ही चल रहा है।
तो ऑलरेडी करेक्टेड है वो, है?
हाँ कुछ करेक्ट है। पानी
थोड़ा सा आप लोग इसको चेंज करने में ऐसा होना नहीं चाहिए।
अब हो गया परमानेंट सोल्यूशन निकाल।
हो गया सॉल्यूशन?
और ये माइक नहीं चल रहा, इसको नीचे रहे। आपने नहीं होगा हमारी।
चला दो जरा, आवाज बढ़ाओ।
आवाज खोल बोल।
माई सेल्फ शुभम मिश्रा, मैं लखनऊ से बिलोंग करता हूँ एंड करेंटली मैं दिल्ली में हूँ। 18 दिसंबर 2020 को मेरे को 7 बजे करीब चेस्ट में पेन उठा अचानक से। देन धीरे धीरे पेन बढ़ते बढ़ते इतना बड़ा कि वो बिल्कुल मतलब बर्दाश्त के बाहर था। फिर मैं जहाँ पहले हॉस्पिटल में गया तो उन्होंने मेरे को बोला कि इट्स हार्ट अटैक
Can
एंड
we
यू
start
हैव
now?
ओनली 15 मिनट्स। देन उन्होंने मुझे अपोलो रेफ़र किया। फिर मैं अपोलो जब पहुंचा तो मुझे रात में फिर सर के पास एडमिट किया गया। देन उस रात 18 दिसंबर की रात को अगर मेरी लाइफ सेव हुई है तो वो सिर्फ सर की वजह से, एंड ही वाज अ गॉड फॉर मी एट दैट नाइट।
जब ये रात को 11:30 बजे के आसपास अपोलो पहुंचे तो उस समय मेरे पास फोन आया कि एक पेशेंट है जो कि यंग है, 25 ईयर ओल्ड, उसको दिल का दौरा पड़ा है और बहुत सीवियर पेन में है, आप आ सकते हैं? तो मैंने खाने बैठ गया था, बस 2 मिनट में खाना खत्म किया, 11:45 तक हम पहुंच गए। मैंने ऑर्डर कर दिया कि पेशेंट को कैथ लैब में ले जाइए। कैथ लैब में आने के बाद सबसे पहले ये लाइफ सेविंग प्रोसीजर होता है। अगर किसी को दिल का दौरा पड़ा है और सीवियर पेन हो रहा है तो हमको सबसे इंपॉर्टेंट बात होती है कि अगर हमारे सुविधा एंजियोग्राफी की उपलब्ध है तो सबसे पहले एंजियोग्राफी की जांच करके देखते हैं खून का थक्का कहाँ पर है। अब मैंने एंजियोग्राफी करी, उसके पहले मैंने 2 चीज और करा। ऐसे केस में, हार्ट अटैक के केस में, यंग पेशेंट है, बड़ा दिल का दौरा है ईसीजी में, तो सबसे पहले इंट्राएओर्टिक बैलून पंप लगाया, जो कि एक मशीन होती है जो कि ब्लड प्रेशर को कंट्रोल रखती है, जिससे कि ब्लड प्रेशर फॉल ना करे और थोड़ा बढ़ा देती है डायस्टोलिक। उसके बाद फिर हमने एंजियोग्राफी की जांच की। अब ये एंजियोग्राफी की जांच में दिखाना चाहता हूँ, ये मेरे लिए लाइफ के लिए सबसे इंपॉर्टेंट था, क्योंकि जैसे ही मैंने एंजियोग्राफी करी मुझे एकदम ऐसा शॉकिंग था, बिकॉज द ब्लॉक जो था यहाँ पे 100% था और क्लॉट था यहाँ पे, और ये लेफ्ट मेन आर्टरी है, ये एलएडी है और सर्कमफ्लेक्स है। अगर ये क्लॉट हम थोड़ा सा भी इधर खिसक जाएगा तो ये आर्टरी में भी आ जाएगा, और अगर इस आर्टरी में क्लॉट आ गया तो पेशेंट विल नॉट सर्वाइव ऑन द टेबल, क्योंकि ये दोनों नस फिर बंद हो जाएंगी। उस समय एक ही नस बंद थी और दूसरी चल रही थी, ये चल रही थी, 3 नसें होती दिल में। तो जब मैंने ये देखा तो उस समय सक्शन किया, इनका खून का थक्का बाहर निकल लिबरेटेड। थैंक यू वेरी मच। So we move on to the next session, and this session also is having 5 talks. One will be from Australia. Our friend Dr. Rohan Jaisinghe will be speaking about non-valvular structural heart disease. Then we'll talk, our colleague Dr. Vanita Ora will talk about the recent
Recording in
advances in
progress.
pacing, leadless pacemaker especially. Then our colleague from Delhi, from GV Pant Hospital, Dr. Vimal Mehta will speak about lipid-associated CV risk management. Dr. O.P. Sharma, our senior colleague in Apollo, physician, will be talking about type 2 diabetes mellitus on Zoom. Then Dr. K.K. Pandey, our surgical colleague, will speak about diabetic foot management, and then Dr. N.R. Shastri will talk about the gisopramide in ventricular arrhythmia. I would request, we are getting very, very late, and I request all the speakers to stick to 10 minutes, and except for Dr. Rohan Jaisinghe, who's our star speaker also, and a good friend. So is he connected on Zoom, Dr. Rohan? Can we have Dr. Vanita is here. Dr. Bagga, please come as usual. You are continuing on the as a chairperson and panelist, and Dr. Vanita is not here as of now. Dr. Vimal Mehta, please be on the stage because you are also speaker here for the time being, and an extremely brief history of percutaneous structural intervention. So Dr. Rohan Jaisinghe is from basically from Australia and a small, big city there. Our friend, I have been invited to Australia several times by him, and Sydney, and he's from the city which is just getting the name. Rohan, Dr. Rohan?
Yeah, can you hear me?
Yeah, you can hear you. Please introduce yourself. I'm forgetting the name of the city, which is very beautiful city of Australia. What is the name of the city?
Yeah. Greetings from Gold Coast, Queensland.
Gold Coast, yes. One of the most beautiful small city of Australia. So, Rohan, we cannot see your face.
Yeah, so I've got my presentation on. Dr. Gupta, Professor Gupta, we have a lot of respect for you. You're a legend, as we know it, and it's a great privilege to have been invited to give this talk to this esteemed conference. And I'm congratulating you on organizing an exceptionally successful conference on behalf of the great nation of India.
Thank you, Rohan. Rohan, please introduce also a bit what you are doing yourself and which hospital you are associated and what intervention you are performing before you go on to the talk.
Oh, yeah. So I'll do a brief introduction of myself. I'm Rohan Jaisinghe. I'm the head of the cardiology unit and professor of cardiology at the Gold Coast University Hospital, Griffith University Medical School, Bond University Medical School, and Macquarie University Medical School in Sydney. So I do interventional cardiology as well as general cardiology. I set up the unit here and developed it to a tertiary quaternary referral center over the last 20 years. I started the international conference similar to that of TCT for the first time in Australia in 2003. And in 2004, our repeat iteration, we had the good privilege of having you as a guest speaker. Since then, that has been ongoing as the NZ meeting, which is the National Innovational Meeting of Australia. But since of late, I have started another meeting focusing on non-valvular structural innovation because PF4 ASD closure is my forte in addition to coronary innovations. And we do all innovations, TAVI, mitral valve innovations, cardiac left atrial appendage occlusion innovations, so all types of innovations as well as innovations and a lot of research. So I have a huge research profile, and I've invented a mitral valve replacement solution which is manufactured as Tendyne with multiple patents under my belt. Thank you very much.
Rohan, we cannot see your face. Can you put on your video?
All right, okay, just
At the same time, I have the privilege of having Dr. Abdul Rashid Khan and Dr. Mansoor Ahmed continuing as a panelist and chairperson during this session also. And Dr. M.K. Das is also, I think, there. and Dr. Fayaz Ali. Okay, so we go ahead. So we have a chairperson, Dr. Vandana Bagga and Dr. Vimal Mehta as of now. And please go ahead with the talk, and very nice to have your words. You have a fantastic voice. You should also become a singer, I think, in future. You're doing a lot of other things also. Please go ahead, Dr. Rohan. Still, we don't see your video.
Yeah,
For-
I'll show myself at the end of this talk. We don't want to unsettle these presentations I've already loaded for you guys. And my warm greetings and congratulations to the panel as well. I'm going to make a brief presentation on the history of percutaneous structural interventions that are non-valvular, which has a longer history than the valvular interventions that we know. So non-valvular interventions include atrial septal defect interventions, PFO closure, VSD closure, particularly muscular VSDs, patent ductus arteriosus closure, left atrial appendage occlusion, paravalvular leaks closure via percutaneous means, and arteriovenous malformations and fistula closure related to the coronary tree. So PFO closure is predominantly indicated for the prevention of recurrent strokes. Patients who are have a contraindication to oral anticoagulation are particularly indicated for PFO closure via percutaneous means, but emerging evidence indicate that PFO closure via intervention is superior to long-term anticoagulation. So it has become the standard of care in our country, and I'm sure it is so in India as well. For PFO closure for primary prevention can be considered in high-risk paradoxical embolism patients. Particularly, there's a tendency for thrombosis. Also for vocational requirements such as deep sea divers. On the Gold Coast, we have a lot of deep sea divers who, if they have a PFO, can suffer from decompression illness. So they become candidates for PFO closure. Also, those who are involved in recreational activities such as high mountain climbing and also recreational diving. And also, since of late, we do a lot of patients who have migraines with aura, having their PFOs closed with the use of Amplatzer device or Figula device or the Go cardioform device. Depends on the institutional as well as national approvals. Different countries have different devices, but I think Amplatzer device is universal. So once again, to recap, the indications are secondary prevention of stroke, transient ischemic attacks, embolic myocardial infarctions, peripheral embolism, decompression incidents, and high altitude pulmonary edema. For primary prevention as well, we can use PFO closure. Aggravating contributor factors would be included in the anatomy of the PFO, such as atrial septal aneurysm, or if there's close to Eustachian valve or a Chiari network. Also, those who have a prothrombotic state, people who have a tendency to suffer from deep venous thrombosis, recurrent pulmonary embolism, pacemaker defibrillator electrodes that needs to be protected for, embolism-prone surgery, such as major orthopedic surgery and cerebral in-sitting position. Those patients prior to the operation may benefit from having their PFO closed. If there's planned pregnancy in a patient with high-risk future PFOs, or those with carcinoid tumors that can embolize and become systemic in the circulation, and also special congenital situations. Also for therapeutic purposes, those who suffer from recurrent and chronic migraine with aura, platypnea orthodexia syndrome, exercise desaturation syndrome, as well as sleep apnea. And as I said once again, those who are in high-risk vocational or recreational activity involvement, such as deep sea divers, mountain climbers, highlanders, frequent flyers, brass musicians, glass blowers, tile setters, military jet pilots or acrobatic pilots, astronauts, commercial drivers or pilots who are at risk. So as I said, percutaneous non-valvular innovations have a longer history than valvular innovations. The first PFO closure device was implanted in dogs in 1972. This device consisted of a paired umbrella, each consisting of 6 stainless steel struts ending in hooks, and it was manually deployed, and it was a success. So then in 1975, King and Mills did the first percutaneous closure of an ASD. But prior to that, we have seen surgical closure of ASDs since 1952. And there's been continuous innovation of and development of percutaneous innovation of the ASDs, particularly the secundum type ASDs that are amenable to percutaneous innovation. Observational studies have shown that percutaneous closure outperforms surgical repair with lower rates of early complications, atrial flutter fibrillation, systemic thromboembolism, ischemic stroke, or all-cause mortality in a 4-year follow-up period. So this is the first device that was used for percutaneous closure of an ASD. As you can see, that is similar to the Go cardioform device. This was the press release that took place after the first percutaneous innovation was carried out way back in the 20th century. So there were 3 devices that were used in the early days of percutaneous innovation of the atrial septum. They were the Rashkin's single umbrella, which is an experimental device. Series of patients had it inserted in the early 80s. Then lock clamshell occluder device, which was a successful device similar to the Rashkin's double umbrella, but it was suspended in its use in 1991 because it could not be extracted, because once it's deployed, it's locked. As you know, the current devices, particularly the Amplatzer device, can be retracted if there is an issue with the deployment. Then we have button device, which was introduced in the 1990s, similar to the clamshell occluder. It had widespread clinical experience, however, failed to fulfill the FDA requirements, so therefore it was discontinued in the 1990s. In 1990, Babbage and the co-group developed the European ASD closure device, and that too had modified success. A very useful device was used as an umbrella structure with polyurethane covered frame and 5 nitinol arms, nickel titanium alloy. It was implanted via an arteriovenous loop to stabilize the track for percutaneous delivery. It used a 11 French sheath, as you know, access via the right femoral vein and exit via the left femoral artery. However, this too did not stand the test of time. This is a snapshot of what the device looks like and how the deployment takes place. Once again, the core principle is similar to that of the widely used Amplatzer device, and it was done under transesophageal echocardiogram guidance. Then we had the monodisc device. Once again, limited trials did not stand the test of time, so those devices were discontinued soon after. This is another picture of the monodisc device. These are not in use anymore, only in history books and chronicles that you can see these. An Indian American by the name of Das developed in 1993 the Angel Wing device. Just before the phase 2 trials ended, the device was discontinued and abandoned. However, it had some significant promise. But as you know, a lot of these startup devices don't see through to the completion of approval process simply because lack of time, lack of money, and lack of opportunity. This is how the angel wings device looked like. Cardiostat Starflex. These were developed in the late 90s and early 2000s. These were quite widely utilized, but once again, did not stand the test of time. So therefore, they are not in current usage, but some of the pivotal trials in the early 2000s were done with the CardioSeal and Starflex devices. So you can see this is the Starflex device, very low profile, does not have too much metal in it. It's a safe device, but deployment was not as smooth as it is with the current generation devices. SoliSafe septal occluder was a self-centering device consisting of 2 polyester patches and 8 wires and fine oxide cobalt-based alloy, which attached 2 wires and held on both ends. SoliSafe was also discontinued by the manufacturer after reports of device-related erosions. So those who had the device are required to have routine screening with imaging to detect any erosions sooner than later. So this is the SoliFlex device. As you can see, that it involves the incorporation of a lot of metal elements, hence the risk of erosion. So the current devices that have the FDA approval, CE approval, and Australian TG approval are Amplatzer septal occluder and Go Helix cardioform septal occluder. We also have the Occlutech Figula or Flex occluder. We do not have the LifeTech Sera ASD occluder or Sera Flex ASD occluder. Cardia, HSEP 1 and 2 and UltraSep 1 and 2 is not available, but it's available in the US. And NIT occluded ASD device is also not available in this country. So that is a brief introduction to the history of non-valvular structural interventions and the development timelines and pipeline. So thank you very much for your attention, and let me see whether I could get myself on the screen.
Hello. Yeah, thank you, Rohan, for a very comprehensive description of the devices and non-structural, non-valvular heart intervention, which is another a big deal. So I would request you to stay back in this, and we'll have a next session, and then we'll have a quick panel discussion. In the interest of time, I will request all the speakers to stick to only 7 minutes or 8 minutes. So next talk will be our colleague, Dr. Vanita Arora, who will be talking about, Dr. Rohan, you stay back, we'll have a discussion maybe after
I'm here.
Okay, so Dr. Vanita Arora, she is having a specialization, especially in electrophysiology, pacing, but of course she do other clinical cardiology, other interventions also. So may we have the slides of Dr. Vanita Arora. She is our colleague in Apollo Hospital, Delhi, and very well trained in these new pacemaker system and all. Thank you.
Good afternoon, everybody. Thank you, Dr. Vivek Gupta, for giving me this opportunity to talk about what is the future of pacing. And leadless pacemakers have come a long way and in a very good way. So in next 7 to 8 minutes, I'll be just speaking about what has gone new in the leadless pacemaker also. This is our standard care of pacing, where we used to do transvenous pacemakers in patients who require it. But over the time, over the years, we have all seen these complications occurring, whether it is in form of hematoma, erosion, lead breaks, lead fractures, insulation breaks. So all these things, they started happening, and then we were at a loss of how to help these patients out, because these patients would spend a lot of money because of repeated admissions, and they would also have a lot of pain because of repeated procedures. And this is not only true for India, but for worldwide also. These are the kind of complications we have been looking at and trying to look at the solution to this. And the lead formed the most important Achilles heel in the entire procedure. So this thought is not new. It started in 1970. 1967 was the first implant, human implant, which was done, a transvenous implant which was done. And within 3 years, our senior people, they realized that there was a need for a leadless pacemaker, and the first leadless pacemaker was created. Although over the years the designs have changed and the technology has changed. This on the left side is a picture of the a person who was given the first transvenous implant, and now you see the leadless pacemaker. The size has been reduced so markedly, and the entire trajectory has been compiled into a small capsule which is of the size of a vitamin pill. This was the first leadless pacemaker which was launched in India in 2016 from a company called Medtronic. This is known as Micra. It had nitinol tines. It was it is 3 Tesla MRI compatible VVIR single chamber rate responsive pacemaker. Now, leadless pacemaker as of today has certain indications. It is not meant for all patients, so these have been compiled as the indication, especially the venous access and infection in patients. These are two major indications where leadless pacemaker can be done. I had the opportunity of doing the first leadless live case transmission during TCT India in 2016. And this is a history of a patient who was 60-year-old, and he had a transvenous pacemaker implanted in 2014 at a government hospital. His pocket got infected. They cleaned the pocket, put back the pacemaker in the same pocket, and it happened that the patient got infected again. He went to a private hospital, subpectoral pocket was made, and the pacemaker was implanted there. Now he went okay for 3 years. Then he had a RV lead malfunction, and there, when the new RV lead was put, the pocket site infection came up again. He came to us with this extrusion. We removed all the leads and we implanted the leadless pacemaker, which comes as a solace in these patients, so that the infection is taken care of. Otherwise, till you remove the device and everything, patient has to be on a temporary pacemaker. It becomes a havoc. Another patient who was running around with the sinus, draining sinus for past 2 years. This was a staph aureus positive patient, and we removed everything and we gave him a leadless pacemaker. Another patient with the bad keloids on the chest, and because of the previous surgeries. And this patient, of course, in case I would have given him a transvenous pacemaker, the pocket would have got infected again. So we gave him a leadless pacemaker. When you have the access is taken through the femoral route, but when you have femoral access which is not available, and or there is a lot of tortuosity or interrupted IVC draining into the left SVC draining into the heart, then what you do is actually you have to change the thinking and go on the other side of the table to do the jugular implant. This is the first jugular implant we did, and it was the first in Asia Pacific, in fact. Doing jugular, the access has to be taken, and the sheath is 27 French. So it becomes a little challenging, but with meticulous approach, it is possible and quite doable. So this is the patient who went back home. The newer paradigm of pacing is the screw-in mechanism leadless pacemaker, which has just been launched there. We did the first AVR implant from Abbott in the country on 11th of November 2024. And the total technology has changed, though it is still single chamber, which has been launched in India. But the dimensions is small. The projected longevity of the battery is wonderful. It is more than 17 to 20 years. And the fixation is, of course, with the helix. The retrievable snare is available in the catheter in case you need to retrieve and the capsule and implant it at a different position, which was not possible with the earlier devices. So we used to leave micra inside the heart. Up to 3 micra can be adjusted can be taken in the right ventricle. But this is possible with AVR to retrieve the device. The mapping can be done prior to the fixation. The screw-in mechanism is quite spongy, and we can place the the AVR on the septum, map it to see if the current of injury is good, the sensing is good, impedance is good. We go ahead and then take the shot, and we screw the capsule in, and at the time of implant the injury settles very well, and it becomes a good implant with the good parameters. The catheter has totally changed. This is the catheter for AVR. It has different ports now in the same catheter, but we the electrophysiologists who are used to doing ablations are used to such kind of catheters being used. And this catheter is a very interesting thing. It gives us a precise location, and the screw-in mechanism becomes very precise. So, but the size of the catheter is still 27 French, so we have to be very careful. The anatomical positioning is done in a total different way, where you have to understand which surface of right ventricular you are going in. And this is the implant that we did on the first implant. The safety and efficacy has been very nicely analyzed in the review article that have been published. And now it is actually the time of dual chamber leadless pacemaker, which is putting another capsule in the right atrial appendage. This is being done worldwide, but in India, well, still DCGA clearance is awaited. So we will be having that clearance by the mid-year 2025. Then we will be able to do actually a true dual chamber leadless pacing. This is how the mechanism works in this thing. You see the right atrial appendage, you take a dye shot to see the shape of the right atrial appendage. There is this mechanism of screw-in available. There is a screw-in screw actually for atrial implantation, and this is how it is implanted. The earlier AV micra, which has come in the VDD mode, you have to keep the sinus rate below 70 to have a AV synchrony maintained. But with true dual chamber pacing, 1:1 pacing, A pace, V pace is beautiful there. Now, what do we look at now? Even now, we are looking at the future of leadless pacing. We are looking at doing CRT with the wireless left ventricular endocardial pacing. This is the WISE system, which is now coming up. We implant this in the left ventricle, the wall that we like, and we can go ahead and do the CRT, which can be totally leadless. Then we are looking at doing conduction system pacing with the leadless pacemaker. By mapping the left bundle, we can implant this pacemaker and on the left bundle and achieve a actual true conduction system pacing. And this is not a fiction or dream. It has already become a reality in US. Dr. Vivek Reddy has already done the first case of this conduction system pacing. So just ending my talk at a very quickie note. It's a bit freaky with this wireless technology. So this is how the things are going to be. We are going to use the Bluetooth technology in a big way for our future to talk to. We will have capsules in different chambers of the heart, and we will be using the Bluetooth technology to talk to each other. Thank you so much for your patient hearing.
Thank you, Dr. Vanita. Please stay back for the discussion after a while. May I have the next speaker is our friend from GV Pant Hospital, Dr. Vimal Mehta. He'll be talking about the lipids, and very important, cholesterols are causing a lot of havocs. Whether actually they are causing or not, he will tell, and how to stabilize the cholesterol to the prevention of coronary artery disease. So he will talk about lipid-associated cardiovascular risk assessment and management. Dr. Vimal Mehta, Director, Professor of Cardiology, GV Pant Hospital, New Delhi.
Thank you, sir. I give my heartfelt thanks to Professor Vivek Gupta sir for inviting me and allowing me to share my thoughts and for this very, very important and well-awaited conference. I mean, sir does it annually. And without wasting any time, my talk is on lipid-associated cardiovascular risk assessment and management. I've been principal investigator for various multinational drug trials. In fact, 7 or 8 trials are ongoing at this point of time. And on lipids itself, I have about 25 publications in the last 4 years or so, and winning awards on mainly lipid-associated papers on the way. This was one international award. So cardiovascular diseases are #1 cause of death worldwide, including in our country, and this is because of the high prevalence of risk factor. In fact, over the last 10 years, the cardiovascular disease prevalence have increased by about 30%, and consequently mortality has increased by about 20%, despite huge number of advances in last decade and a half, including introduction of huge number of drugs like SGLT2 inhibitors, GLP-1 agonists, and lots of lipid-lowering therapies. The age-adjusted death rates because of cardiovascular disease have decreased in the Western population and in the US since last 50 years and continues to decrease, whereas we are, unfortunately, the prevalence of cardiovascular disease mortality is increasing in our country, and even the latest charts show that we are at a very, very, bad footing in the sense that cardiovascular disease, especially in the South Asia, and including our country, the mortality continues to increase. In fact, the prevalence is about 4 times higher compared to Americans. And not only prevalence is higher, but the disease presents at a very young age. As Professor Vivek Gupta sir showed so nicely, only 25 years old young, boy sort of, and he had heart attack. So, which is very, very disheartening. So why we people are doomed? Why our population doomed? There are huge number of data now available. This is, I'll be, brief in my slides as has been, advised. Because of paucity of time. Nevertheless, UK Biobank Professor study was there, which included 470,000 patients or so, and it looked at why South Asians compared to Europeans have increased incidence of heart attacks. So in this study, patient followed for 11 years, and the incidence of at the onset of the before 11 years, all of them were free of cardiovascular disease, but over 11 years, the cardiovascular disease mortality was twice compared to Western population, and this was predominantly because of the prevalence of increased number of risk factors in the Southeast Asians compared to Europeans, and predominantly 20% patients were diabetic, and huge amount of dyslipidemia in the form of hypertriglyceridemia. We know that we are now the diabetic capital of the world, with the prevalence of diabetes increasing, going up to now at this point of standing at 9 to 10% in the adult population. Coming out to dyslipidemia, the mean LDL levels in US have decreased by 15 milligram per deciliter in last 15 years or so. Whereas if you talk about India, this is 2014 data and this is 2023 data. You see almost whole country, in the whole country, all the states have prevalence of hypertriglyceridemia of about 25%. That is 25% of the population has increased number of triglycerides, and cholesterol levels. Cholesterol levels, although not that we have lower LDL levels, but still it continues to increase. Now, Interheart study done 20 years back showed that population attributable risk of dyslipidemia is as high as 50%, meaning that if we take care of the dyslipidemia at population level, we can control much of the heart disease. And based on this and other data, Lipid Association, with the office, I am the main member, and we publish huge number of data. We for the first time gave for Indian population a LDL goal of less than 15 patients who have very high risk, meaning that they have already established atherosclerotic cardiovascular disease, or they have multiple other risk factors which may predispose them to develop atherosclerotic disease. At that time, the prevailing LDL-C goals all over the world were less than 70 or so, including in Europe and in America. Now, what is the basic problem with this thing? This is the lipoprotein, and you see these lipids are insoluble in blood. So they are carried in the ball-like structures called lipoproteins, where cholesterol and triglycerides are, surrounded by hydrophilic shell of small amount of cholesterol, phospholipids, and protein component called apolipoprotein. And all they are derived either from hepatocyte or from the intestine, from the food. And VLDL is the basic one over here. And ultimately, their aim is to provide energy to the body. And as the VLDL particles go across the body, rotate, circulate, then they give triglycerides or free fatty acids to myocytes, adipocytes so that they can utilize it for energy consumption. Ultimately, we have a particle called LDL, which is rich in cholesterol compared to VLDL or chylomicronamide, which is rich in triglycerides. Because triglyceride has been taken out, so they become smaller. Anything less than 70 can go into the arterial wall and cause havoc and atherosclerosis, which, like Professor Vivek Gupta sir showed that case. LDL is the predominant lipid lipoprotein in the blood. 90% of it lipoproteins. If we take lipoprotein, it is 90% is LDL. And in fact, it is a moving target. Controlling it has been a moving target throughout the decades. In fact, only 20 years back, we thought that if you reduce it below 125, you are not going to gain any benefit. Now we are talking the lines of tens or so. Goes as low as 10 milligram per deciliter. Heart protection study, which studied statins, showed that it is highly beneficial. However, despite statins being highly beneficial, there is huge amount of residual risk, such that around over 5 years period, almost, we cannot prevent about 2/3 cases despite patients being on statin, patient will still continue to suffer they will continue to have events. Events will be lowered, significantly lowered by about 25%, but 75% are still predisposed to event. So question is, how can we further reduce the risk of, cardiovascular events and death? High intensity. So one of the major aspect which was being studied was that can we lower LDL further, because LDL lowering capacity of statin is only about 50% or so. So we had newer drugs coming up. STMI was there, which decreased LDL by another 15% or 20% or so, but the relative risk reduction was only 9%. I mean, very, very mild benefit. And whereas then PCSK inhibitors came, 4-year study was there. As you see, the mean LDL achieved was 30, and we had salutary reduction, about 20% reduction in the combined endpoint of death, MI, and stroke. I was part of this study, and based on this, basically what they do is PCSK inhibitors, they increase the number of LDL receptors, because PCSK9 is the killer of LDL receptors. When you block PCSK9, you have more LDL receptors on the liver surface, so that they can catch more LDL from the blood. It goes into the liver and is metabolized and taken out. So it increases, PCSK9 inhibition increases LDL receptors on the substrate hepatocyte by 2 to 3 times, because there are millions of them. So 1 million, for example, they are there, so it becomes 2 million, so huge number. This was our paper in the prestigious Journal of Clinical Hepatology, and where we again in 2020 gave the first time the goal of less than 30, and this is now accepted. Now we know that achieving this goal reduces events as well as decreases the amount of cholesterol which has already been deposited in the arterial wall. Now we have oral drugs available. Inclisiran is available, which is the dosing. It blocks the synthesis of PCSK9 in the blood. You have to give at baseline, then at 3 months, and then every 6 months, and it decreases LDL by another 50% or so. You give patient statin, his LDL was around 200 to begin with, it becomes 100, which is very high. You give inclisiran to the fellow, and it is now 50 or so. So it's a beautiful addition. We have lots of drugs. This was from my paper, which was recently published, listing all the drugs. So first we give with statins, STMI, then bempedoic acid, another agent, and inclisiran. Recently, this was another paper which was published few months back with me as a primary author. But despite lowering LDL to very low levels, we know patients still have heart attacks. So one of the important reasons is inadequate control of LDL. Second is hypertriglyceridemia. Triglycerides themselves are not atherogenic, but the cholesterol component of the triglyceride lipoprotein can get deposited. Further, they can cause inflammation. So triglycerides are from that angle very important, especially in patients with hypertriglyceridemia. Another important point is that more the triglyceride level in a given person, then the small dense LTL particles are very high. So you have to take care of both of them. Now we have evidence from reduced trial and other trials that reducing triglycerides, tackling triglycerides results in reduction in events. Lots of papers are there. I've been part of most of them, and this is I will not go too much into detail in the interest of time. Last 2 or 3 slides. Basically, ApoB is another measure because each atherogenic particle has one ApoB attached to it. So ApoB gives us a estimate of the particle numbers. LDL gives us the total cholesterol. This gives us the particle numbers. So in the same cholesterol or LDL level, we can have huge number of particle numbers, which can, so obviously on the right side, if they are, let's say, lipid particles, so same mass, but more particle numbers means more atherogenesis. Lipoprotein, another small lipoprotein which has ApoA attached to it, which is again atherogenic. So to if you want to control atherosclerotic risk of a given person, you have to take care of LDL, non-HDL as well as ApoB. And what you do is, in my last slide, how to apply it in a given person. For example, LDL in this case was 140. And your goal is less than 50, so you subtract 140 minus 50 is 90, so you need 90 by baseline is 64% reduction, so you need at least 2 drugs. And if if your goal is less than 30, for example, patient is diabetic based on risk algorithm, then you need at least 3 drugs. So giving statins is not enough. Thank you.
Vimal, as usual, you spoke very well. And actually, lipids are very important, and we have to keep our LDL. Now, the new guideline says less than 70 in a person who is otherwise also not having major risk factors. So it's very important to keep the cholesterol checked, and that is the only way, because recently we started having more young at heart attacks, especially after COVID. So we have to be very cautious, and so we quickly move to the next talk, which will be Dr. O.P. Sharma is ready with the talk, with the online talk. Is he ready with the Zoom? Is he ready? So, okay, so we'll be talking about diabetes, which cannot miss diabetes any conference, because 30% as of now, the incidence of diabetes is about 30% in coronary artery patients and about 10% in general population. So it is one of the major risk factors, preventable risk factor, and therefore we have to work on the preventable risk factors. There are, of course, genetics, which is for coronary artery disease, especially where you cannot do much. So the purpose is to reduce the morbidity and mortality, especially in coronary artery disease, or rather not having CAD to the extent that patient can die. So let us have Dr. O.P. Sharma, who is a senior colleague and internist and physician in Apollo Hospital, Delhi, and specialized in geriatric medicine. He's not available on the Zoom. He will take time so that we can have next talk. Okay, so we can move on to the next talk. Dr. K.K. Pandey is here. I'm welcoming Dr. A.K. Kundu, who is a part of this conference, and Dr. Podar, who is a senior person from the Delhi Medical Association, having major post to come and join this conference. So we have Dr. N.R. Shastri here. While we are waiting for Dr. O.P. Sharma, so he is joining. So we can have some panel discussion while we are here. So, Dr. N.R. Shastri is here?
After 6 p.m.
Okay, in the evening. Okay. So, we can have some Dr. Rohan. Hello. Rohan, are you available? From Australia? Coming back to the lipids, very important. Vimal, what do you think? What the general, you gave a lot of scientific talk, but this is going Facebook Live, this is YouTube Live, and a lot of people will be watching this program this session in future, in a few days' time. So just give me very crisp answer. You can have a mic. How much should be the level of LDL, and how frequently should we check cholesterols? I'm talking of the general population.
Yeah.
That's very important because you see, people are very worried about the young heart attacks. There is no doubt.
You showed a very, case which we see, unfortunately, very often, actually, all of us see. So, as a general population, everybody, and these are written in our Lipid Association of India guidelines also, and that everybody at least should have one lipid file when they enter the college, that is around 18 to 20 years of age. Everybody, regardless of the risk factor, regardless of the family history, they should have lipid file done, and accordingly, if it is within the normal range, and it should be read by somebody from general physician or somebody from cardiology, and based on that, if it is normal, then every 5 yearly, and if it is, let's say, unfortunately, it is not okay, it is very high, then lifestyle measures, etc., will be instituted based on the medical advice, and it will require to be repeated maybe after 6 months to 1 year, depending on the increased number of the intensity of increasing the lipid levels. If somebody has a family history, people will come and that my father died at, or had heart attack at 40 years. We see it so common at GP, a huge number of patients. So such patient, if they have younger children at home, they should be even at younger age as low as the second recommendation, 9 to 11 years, they should have a lipid well, so that if their levels are high, we can intervene by lifestyle measures, and if required, by statins, which are more or less innocuous drugs. They lower the lipid levels, but side effects are very, very minimal or practically non-existent. So this is about the general. For those who have developed a heart attack, once a person develops heart attack, the chances of recurrent heart attack are very high. If you look over the long term, because we are not going to say that patient will live for 1 year or 2 years. We want them to live for, even if they have a heart attack, for another 20, 30, 40, 50 years. So the lower the LDL levels, because it is the cholesterol which, LDL or cholesterol which get deposited. So it is logical to reduce LDL to as low as possible, and thereby preventing the future heart attacks. And now we know that decreasing heart attack, decreasing LDL is very safe. As I showed in one study where we took part, Indian patients were there, about 300 patients were there in that study, over 27,000 patients, achieving as low as 10 milligram per deciliter LDL. Normally, if you measure, it will be somewhere around 80, 90, 100 or so. The average is Indian is 100. So going as low as 10 is absolutely safe, is not giving rise to any side effects. So lowering LDL is the key. In fact, if in certain population, in my last line, genetically, some people have very low LDL, around 50 or so. These people are protected from heart attacks for most part, 80 to 90% protection, regardless of presence of other risk factors. So the lower the LDL is maintained, we can have prevention of unfortunate events like Professor Vivek Gupta sir's case, young MI, 25 years.
As I was listening to a talk by Dr. One of the very important cardiologists. I'm sorry what's happening to my mind, I'm not remembering the names. Dr. Jagat Narula from USA. He has a mastery in this, and he gave a talk recently in CSI also. Stop CAD. So he said that when the child is born, in the fetus and also the young child less than 1 year or less than 6 months, the LDL levels are very, very low. So that means we are reaching to the conclusion that the lower the better.
That's right, sir.
So lower the better, and maybe you can really stop CAD. CAD means coronary disease. So okay. So quick comment from Dr. Mansoor Ahmad. Please unmute yourself from Pakistan. What are they following the guidelines? Dr. Mansoor. Sorry, he's on the phone. Dr. Mansoor. Is Dr. Opi Sharma ready? Just find out. Dr. Mansoor is okay. Okay, so
yeah. Sir, you rightly said, because when we talk about Indians, South Asians, Bangladesh and Pakistan, all, this actually caters to our guidelines, cater to, for the sake of, because we are talking in India, so it caters to all these South Asian countries, including Pakistan and Bangladesh.
Dr.
And
Mansoor.
Sri Lanka.
Dr.
Yes.
Mansoor, what
Sorry,
are the
I
guidelines you're
was
following in Pakistan? Is the same what we follow? One thing I wanted to tell you, all especially on the Facebook, young people, especially non-medical, that mostly we are guided by the pathologist or biochemistry reports, and they still mention LDL. I think less than 130 is normal. The cutoff 130 is not correct now, and they have to change. I think you have to do some information to the all the biochemistry labs all over India that they have to now make it a little lower than what they are already writing. Dr. Mansoor, please go ahead with your thought process quickly.
Yes, I think lipids is probably is one of the most important factor that we should look into because it's a kind of a low-lying fruit these days in presence of such effective drugs that are available. And I think prevention is very, very important. I'm glad it's been mentioned that lower is very, very safe. Social media, unfortunately, is promoting how bad statins are and how dangerous it is to lower LDL. But I think over the years, for decades, literally, I've been a fan of statins and cholesterol lowering. It's one of my favorite subjects. And most of my patients, I would just keep their LDL below 50, and they're certainly very safe. And I think the talk on it is very, very useful, and it's very helpful for me because I feel more comfortable after that. Now, in Pakistan, there is again a taboo, which is difficult to get rid of because of social media. And moreover, as you've just pointed out, the labs actually suggest desirable level so and so and so. Now, it's difficult to explain to the patients who does not visit for a year or two. They think that their level is normal, which is given in the lab report. So you have to tell them very clearly that those levels that are given in the lab is basically for normal population, not the patients. So this has to be made very clear to the patients. And once they understand, I think they all agree and they are all very happy to keep their LDL down, particularly with these newer drugs. Even with bempedoic acid, with the zetamide, and now inclisiran, I think it's possible to work towards lowering LDL to maybe less than 50 and even 30. And I'm very impressed with this talk on lipids, really. And the data the data, as they say, never lies. So thank you very much. It's great.
Yeah. One question which coming into my mind, Vimal and you see, you in Pakistan and especially in Bangladesh, you have almost 100% non-vegetarian population. In India, we have about 50% non-vegetarian and 50% vegetarian population, and number of vegetarian is increasing now, slowly, but yes. So, do you think that the non-vegetarian people, this is very always a question in the mind of the general public, will have a more bad cholesterols as compared to the vegetarian people or not? Vimal, you quickly answer this and then we'll have from Dr. Mansoor. Quickly.
Sir, I see cholesterol intake obviously has a major role to play, and non-vegetarian population, especially, this is not only about red meat and all. I mean, like mutton and all are to be taken in moderation. Number one, more problem with what we see with our colleagues. I mean, I have huge number of friends, and how they cook it. Actually, it is cooked in so much of oil. I mean, the oil is
So
that's important.
to summarize this,
That will
means that
tell
our
more.
non-vegetarian and especially in Asian countries, Southeast Asian, is having a huge amount of the oil, which is not there in the European and American country because they are mostly eating the raw meat. So I promote that for two reasons I am vegetarian. Dr. Mansoor, you should listen that. One reason is of course that it is not that healthy as I feel. And secondly, because I feel that vegetarian is good because we can't kill an animal for our pleasure. Because if you cannot give life, how can you take life? This is my motto. If you cannot give life, how can you take life? Because we are not God, we cannot give life. So nothing against the overall, but I just wanted to know, being non-vegetarian country, do we have a more number of heart attacks as compared to the people who are having vegetarian? What is your thought process, Dr. Mansoor, from Pakistan, Karachi?
Basically, when you talk about vegetarians, you always forget the fact that it's dairy fat which matters more than even meats. So I think the consumption of dairy fat is very, very high, and you need to advise people to cut it down. Now, when you use vegetable oils, then don't forget that having very low fat diet is not so healthy, because you need to have at least 30% of your calories coming from fat to have a balanced diet instead of 40%. So cut it down. You can't stop it, but I usually insist to my patient that they must cut down on dairy fat, because everybody feels in our part of the world that milk is the safest diet and the best diet on earth, which it probably is a balanced diet, but it does have almost 40% fat. So this is what I would advise, that cut down on dairy fat. And of course, vegetarian diet, there is no harm in it. In fact, one of my daughters is not just vegetarian, but vegan. So, so I see both sides. But yes, I think it's dairy fat that matters more than any other fat.
Okay, so I think we have to finish this session. Dr. Sharma is not ready. Maybe he'll come later on. So we have Dr. Omar, our friend from Escorts Hospital. Doctor, if you are having time, Dr. Mansoor, please stay. It's good to have a cross-country talk continuation. And we will invite Dr. A.K. Kundu, who is supposed to share the next session also, along with Dr. Podar, to be on the stage. And Dr. Omar will talk about choice of prosthetic valves in valvular heart disease. Valvular heart disease is an important component of overall cardiology clinic or patients. And we need many times, your surgeon, Dr. Mukesh Goyal, is here. I think he should be chairing this session, more important, because this is going to talk about the prosthetic heart valve. And so many times we require surgical intervention. And of course, many times we also continue on medical treatment. So prosthetic heart valve, somebody has to take his slides. Doctor, somebody has to help him out. What are you doing? So the valvular heart disease, which is especially, we have four valves. I'm talking more of the layman also, because a lot of people will be on the Facebook. We have four heart valves. Of course, the most important valve, which are more diseased, are mitral and the aortic. And pulmonary and tricuspid are less required to be treated. Of course, now we are treating the tricuspid also. The pulmonary valve is mostly congenital. Mitral valve is basically for the mitral valve is basically requiring, especially for the rheumatoid heart. Don't change the laptop. And mitral valve requires, especially in rheumatic heart disease, where you have a severe mitral or stenosis requiring balloon mitral valvotomy, or then if you have associated severe mitral regurgitation, then of course you require mitral valve replacement. Of course, now we have prosthetic. Dr. Deepti, along with Dr. Praveen Chandra, will show, especially in a non-rheumatic mitral valve, where we can do a percutaneous mitral valve replacement also. Regarding the aortic valve stenosis and aortic regurgitation, most of the time we require surgical aortic valve replacement, but many times now we are able to do transcatheter aortic valve implantation, of course started with Dr. Kribier. This meeting is also dedicated to Dr. Alan Kribier, because I told you that we started with ICR conference with Dr. Kribier in 2008. And unfortunately, we lost him at the age of only 79. I would say average aging, age is in US, in France is about 83. But unfortunately, we lost him as a sudden cardiac death. And he had a few stents, but ejection fraction was recently normal. So he never thought of AICD. And in the afternoon, he was taking a lunch, and the evening, while seeing the television or something, taking rest, he was no more. So we had a personal, very close relationship, and TAVI was discovered by him, innovated by him, transcatheter aortic valve implantation. Dr. Mansoor has also some special relationship with Dr. Kribier. You must have met him many times. So everybody, especially Southeast Asian doctors, have been trained by Alan Kribier. It's really emotional to think that he is no more with us. So I have not removed his name. Somebody pointed out from the flyer that why you keeping the name of Dr. Alan Kribier, who is not in the word. Yesterday on the WhatsApp, I said, I have written eternal blessings, or I can say heavenly blessings, something like that. I have no right, or rather I cannot think of removing his name from the flyer, because we started this course with Dr. Alan Kribier in 2008, and he has been part of all our conferences, especially London, Paris, Rome, Amsterdam, Zurich. So all of these places, when we used to do out of India, he was always part of this physically on site. He was not able to come all the time to Indian conferences, but he was always sending messages. I'll show in the evening program the messages which he used to send, but the video message. But this time we'll not be having his video message, but I'll still play the old video message which he has sent for ICR. So let us have Dr. Omar, please. Are you ready with this now? You should be prepared, audiovisual people, prepared with our talks of everybody in advance, rather than we should utilize the time. Dr. Omar is a very dear friend from Escorts Heart Institute, which is one of the premier institute in India. In fact, this Escort Hospital came before Apollo Hospital, I think so. And I think you are there since that time, from the beginning. And he has been basically a specialized for echo. And that is why he's talking about the prosthetic aortic valve, metallic versus bioprosthetic. So it's a very interesting talk in the interest of the audience overall. I would request him to stick to just 10 minutes so that we can continue with the timing.
So thank you, Dr. Vivek, for introduction. So here, little diversion is we are talking about the aortic valve replacement. You know, the aortic stenosis is the most common valve disease in elderly. One of the 8 over age of 75 have a high mortality rate if left untreated. If they are symptomatic, you understand their critical AS is very poor prognosis. When we talk of aortic valve replacement, there are two, that is mechanical valve and this is bioprosthetic valve. And now we know that the tower is also there. So what is the mechanical valve? Mechanical valve is the metallic, basically, most likely metallic and carbolites are there. Then they have a basic thing why we replace with the metallic. They are very durable. But of course, they require lifelong anticoagulation, thromboembolic and bleeding complications are there. They always require INR regulation. The hazard of anticoagulation is during pregnancy. All these are the things which are against the mechanical valve. Now, what are the mechanical valves we use? Nowadays, only bileaflet valve is used in 99.9% of the cases. Other kind of valve like a single leaflet valve or a star valve is not used now. In mechanical valves, the early mortality is 3.1%, that is 30 days mortality. And they require pacemaker implantation, 3% of the cases, external infection, endocarditis, all these numbers are given here. So, though they are stable, though they are very stable valves, but problem is there, still the mortality is there. If you look into the late mortality, the 1 to 2% mortality per year, and the various kind of thromboembolic phenomena, valve thrombosis, all that is there. And of course, I told you about the anticoagulation related issues. So reintervention in these mechanical valves is 8 to 15%, particularly structural valvular dysfunction is very less. But the other kind of problems are there and reintervention is required. When we talk about the biological valves, they improved longevity in new designs and improved risk during reoperation. And nowadays, if you have a bioprosthetic valve, you can have valve in valve. But in mechanical valve, you can't have a valve in valve. If you look into the mechanical valves, now the increased evidence of lower maintenance of INR than currently recommended. Currently recommended is between 2 to 3 for the aortic valve, but nowadays the recommendation is between 1.5 to 2 INR. But there had been the trial, it can only DAPT, dual antiplatelet can be given? No. There are a lot of trials has been done, and we have seen the excessive CV events are there with the DAPT. Various trials has been done with the low intensity warfarin and standard warfarin. Low intensity warfarin has a less bleeding complication and no difference in thromboembolic phenomenon. So nowadays we are looking into the valves with putting the INR values between 1.5 to 2. There are two common valves which we are using nowadays. Is the St. Jude Regent aortic valve, and the other is ONX valve. ONX valve has been seen equivalent to the St. Jude valve. When we talk about the bioprosthetic valve, they normally use the xenografts, that is the porcine or bovine tissues, and they can be stented, stentless, or sutureless. I'll be coming a few words about all of them. These are the common valves which are being used. Now,
So, good
when we look
afternoon,
into
everybody.
how
We
the
are going to
bioprosthetic valves
present to
are
you a
produced
case
is
of
the
a
glutaldehyde
transcatheter
treated
mitral
basically for stability. But this glutaldehyde has also problems. And the glutaldehyde, nowadays, we prefer the mechanism.
I'm so sorry. We are एक Zoom पे meeting चल रही थी Zoom पे, तो they wanted my comment at that time. ना? Sorry, yeah, very very sorry.
Okay, okay. So nowadays, washing for the glutaldehyde is being used, and there's the now perceval valve and the magna perimount. These are the valves has been used. Here we wash out the glutaldehyde with alcohol and multiple other ways. So, what are the complications with the bioprosthetic valve? What chemical contribution, mechanical contribution, and immunological contribution, all these reduce the durability of the valve. Nowadays, new generation valves, the durability is excellent. That 2 to 10% risk-free is 10 years, 10 to 20% 15 years, and 40, while other studies show that 40% regeneration in 20 years. We come across many patients who have been operated 20 years back, but still valves are functioning well. New generation valves are less static configuration, and new generation has Inspiris, and Perceval Plus. The Perceval Plus is a free this is alcohol mixture treated for removal of the glutaldehyde. Regalia tissue is also for the similar thing. We have to reduce the glutaldehyde effect. Design and developments of new biological bioprosthetic valve must reproduce the structure and, more important, the biology of native heart valves. The clinical and hemodynamic outcomes of the perceval valves, you can see the 5 to 7 years follow-up. And our hospital is also part of follow-up. And there is very, very stable valves with the 96% event-free survival. This is the perceval valve. You can see this is just like a tower valve which is put through the aorta, though surgically. This is again a stentless valve. This is also a good one. And now we talk about the you can see the durability and performance of 2000 volt and trifecta valve has been seen. The trifecta was very favorite valve earlier, but trifecta has been banned because of the very, very early degeneration and aortic regurgitation was there. The 1 year follow-up of the Regalia valve, Regalia I told is basically to reduce the glutaldehyde effect, and the Regalia tissue is being used. Now even the tower valves are using Regalia tissue. So concluding these bioprosthetic valve, results of this is meta-analysis was shown that the perimount valve was the most commonly used and had the lowest incidence. Of course, the newer valves was not included in this study, and newer valves had also been shown very effective. Now, a few words about the tower, though the tower is coming in the next few sessions. First tower procedure was performed in 2002 by Ellen Crevier, like we have already mentioned, for the treatment of aortic stenosis in patients with several comorbidities and cardiogenic shock. Since then, tower has revolutionized the treatment of patients with the severe symptomatic AS, as a randomized controlled trials have shown similar, if not superior, outcomes following the tower as compared with the surgical aortic valve. Moreover, several progresses have been made since then and have resulted in a wide armamentarium of our disposal, including bioprosthesis, presenting different dimensions, designs, and diversibility, providing the opportunity to select a device based on each patient's clinical and anatomical characteristics. Important developments. Now, what we are talking tower, we all know about, but what are the important developments? Developments are the seat size has been, delivery system was reduced from 24 to 12 to 14 French. Sealing technologies such as outer skirt and pericardial wrap to reduce the leak of the valve. Frame height was decreased and the sizes of frames upper cells were enlarged to facilitate the continued coronary access. According to the position of the prosthetic leaflet relative to the native valve annulus, the transcatheter valve is labeled as supra or intra-annular. Supraannular valves usually result in a larger effective orifice area and lower transvalvular aortic mean gradients than intra-annular transcatheter valves. Some transcatheter valves can be recaptured and repositioned after implantation, while others transcatheter valves are non-repositionable. So these are the designs you can see. These are the transcatheter valves. This is balloon expandable. This is self-expandable valves. Various designs has come. Latest are Sapien 3 and Sapien 3 Ultra for the balloon expandable valves. Self-expanding valves, of course, you can see the many designs. The group of self-expanding transcatheter includes a wider range of devices. The majority of self-expandable valves are supraannular, resulting in a higher effective orifice area. Rapid ventricular pacing during implantation is not mandatory, and most self-expandable valves are repositionable. They of course have a limitation. They have a limited steerability. So the frame of the Medtronic self-expandable valve, due to its higher radical force, results in considerable risk of conduction abnormalities. So mechanical expandable valve, I am not going to detail what this. Valves with the effective fixation mechanism, that is the Jena valve, I mean they have a paper clip-like fixation mechanism and particularly used for the aortic regurgitation. Of course, we should not forget the RAS procedure, though in pediatric population, there is no long anticoagulation. Superior long-time survival was seen in these valves. So come to the concluding remarks. We see less than 50 years, the SAVR, particularly surgical aortic valve, mechanical usually, or earlier age, the ROS procedure. If the 50 to 65 years age, surgical aortic valve, mechanical or tissue valve. Less than 65, 50 to 65. And more than 65, one can choose depending on the patient, the surgical aortic valve or the TAVR. Of course, more than 80 years, it has to be TAVR. So, decision making in mechanical versus biological valve not only depend on the age of the patient, they are tailored and shared decisions with the patient, particularly looking into life expectancy, career, pregnancy planning, pre-operative condition, AR or more favorable results, limitation and risk. All these are to be considered when we prescribe the bioprosthetic or mechanical valve or TAVR. Thank you very much. Yeah, Dr. Vivek.
I was always considering that with TAVI, why young people are not still in the indication because of the longevity of valve. I always have a debate on this issue. If, for example, a 35-year-old person, severe aortic stenosis, even non-bicuspid, or 40-year-old, he wants TAVR. And because in TAVR, of course, TAVR is a transcatheter aortic valve, which is not a metallic valve, which is a bioprosthetic valve. So overall, the longevity of such valve is not more than 10 years as of now. Although we have patients of TAVI who are, so you have to do a TAVI and TAVI, you have to another valve inside the valve in future. So still the indication for the young patients having a severe aortic stenosis is surgical. So I was talking to Dr. Bernard Prendergast, who is a very another authority of he is the organizer of London Valves meeting in London. He said, I would not be so unhappy to deviate from the indication if the patient insists. Because even if a valve has a longevity of 10 years, at the age of 40, if you deploy a bioprosthetic through the transcatheter non-surgical, then at the age of 55, he may have recurrence of valve failure, what is known as valve failure. Then you can put another valve, again, another TAVI, or who knows, after 10 years, there may be more advancement in this. So there's always an issue, but still, as per the strict guidelines, a young severe aortic stenosis is not a candidate for transcatheter aortic valve implantation. Dr. Mansoor, are you doing some sort of a transcatheter valve there in Pakistan?
Oh, yes, it's being done. And again, because of cost, it's little limited, but yes, it's being done and patients feel wonderfully well actually after that. Now, I think when it comes to valve replacement in the younger one, I just recall one of the cardiac surgeon, he's saying, okay, I'll do it. I'll replace the valve. And this mechanical valve, and she actually called it that we are replacing one disease with another, because these valves, mechanical valves, need long-term treatment and close follow-up. So it's not that you are free of treatment or you are free to travel, you are free to do anything without maintaining your anticoagulant level. So I just hope that sooner or later we move on to bioprosthetic valves, which are more durable. Hopefully, that time will come very soon.
I totally agree, because in bioprosthetic valve, we don't need to have a anticoagulation, which is very important, because anticoagulation means warfarin for life. And so sometimes it is a double-edged sword, because you may have a bleed in the cerebral hemorrhage or whatever. Vimal Mehta wants to have some comment.
I fully agree, because mechanical wells, although guidelines, and we have to go by guidelines and they are based on data only, but we have to realize 10-year incidence of thrombosis or major bleed or death or cardiovascular event is as high as almost 40% or so, even with mechanical valves, even in today's mechanical valves, because many a times patient will miss out on warfarin dosing, or there may be INR changes for so many reasons. So they are not, as rightly said, changing. we are exchanging one disease with another. That is very right way of mentioning it, because so we have a huge incidence of complications related to valve over mid-term to long-term basis.
Can I just interfere? There is another limitation really. The patients, many times they come up with bleeding, and you will find out in history they have taken one of the NSAIDs without even realizing what they have done. So their prothrombin time and INR just jumps from 2 or 3 to 5, 6, and 7, and that's what precipitates the bleed quite frequently. So there are so many limitations with other treatments. So let's hope technology will change. But I like, Dr. Vimal, your approach to medicine, really. You are aggressive, you are pushy, and I'm sure you get your job done.
Thank you. I think,
See you.
we will have a dedicated TAVI session in the evening with the Crebier Symposium, which I have spoken just now. But thank you, Dr. Omar. Please have a seat here. And we move on to the now transcatheter edge-to-edge repair in secondary mitral regurgitation. The case has been done by Dr. Praveen Chandra, our dear friend, and I also colleague, and also from King George Medical College from I. Are you ready with Dr. Deepti? Okay, so Dr. Praveen Chandra is not available in Delhi today. So one of his team member, Dr. Deepti Yadav, will be talking about transcatheter edge-to-edge repair, which is actually known as mitral clip. Secondary mitral regurgitation is an important component of heart failure patient, and many times you can't do You're doing this, na? First, okay, you're doing the first one. Okay, she's going to talk about percutaneous mitral valve replacement. It's a very interesting case in box, which will be shown by Dr. Deepthi Yadav, team of Dr. Praveen Chandra from Medanta Hospital. Mitral valve replacement, as you know, is basically a surgical thing. I mean, most of the time it is surgeon doing it, but recently we have a same valve which is being used for the transcatheter aortic. If it is done in a reverse fashion, in the inverted, we can utilize this valve for treating and deploying inside the regurgitating valve, and which is almost cure. And this is very interesting because many times these patients are not operable. When these patients are not operable, then you have to leave them on medical treatment, and these patients have recurrent heart failure, recurrent hospitalization, and recurrent paroxysmal nocturnal dyspnea, dyspnea on effort, and they are really morbid patients. They may not die, but they have a serious morbidity and also low blood pressure. So these patients are candidate for surgery, but surgery is not technically possible because of severe reduced LV dysfunction, severe reduced LVEF, and therefore this percutaneous technology of mitral valve, deploying another valve inside a diseased mitral valve. I told you this was, we are talking about aortic valve, now we are talking mitral valve deployment in a diseased, dilated aortic mitral valve. She will tell you step by step. But I would like her to be you're talking only this, no mitral clip. Okay, so let us have her views and case in box in next 10 minutes. Okay.
Good afternoon, everyone. Myself, Dr. Deepthi, as sir has already introduced. So I will be presenting this case in a box of TMVR. So this is the case summary: 80-year-old male, hypertensive, diabetic, post CABG plus MVR done in 2010. So patient was doing well, but after 10 years, patient developed this prosthetic valve degeneration. He had severe stenosis as well as moderately severe MR. LVF was around 40%. Patient presented to us with acute LVF and AKI. So the echo and T was done, and which showed that there is prosthetic valve degeneration with the mean gradient of around 12 and moderately severe MR. Aortic cusp was also thickened, but no significant stenosis or regurgitation. And as already told, that LVF was around 40%. So what are the treatment options? First, we have to optimize the medical therapy for acute LVF and renal failure. And then either we can go for redo MVR, but it will be a high risk regarding morbidity and mortality. And the anatomy should be suitable because it is a second operation. And the second option is obviously TMVR. And TMVR is currently FDA approved for high-risk mitral bioprosthetic valve failure and off-label indication for high-risk mitral annular ring failure. And it can be done in high-risk native mitral valve disease with severe MAC and under study for native mitral valve disease. So let's begin the case.
Good afternoon, everybody. We are going to present to you a case of a transcatheter mitral valve in patient. This patient, who is 80 years old, had a valve surgery done using a peri-mount 25 millimeter valve, and after this he was having recurrent failure for the last 6 months. So initially we managed him on medical therapy, but his valve is degenerating quite rapidly and his gradients kept on increasing to the maximum of 24 mean, and peak was 32 and 35. His MR was significantly high, and that is why he was having these symptoms. So this time again he was readmitted after the continuous anticoagulation therapy, and when we admitted him he was in failure, so we managed his failure, kept giving him intravenous heparin, and he did decrease some gradients, but still when we did the TE now and the echo, we found that one of the leaflets is totally degenerated and become very, very thick. So we decided that now we cannot continue on medical therapy. We have to do this procedure of transcatheter.
He had significant mitral regurgitation.
Which
very
you can see in
jet.
other views.
I'll just show you in the other views. Yeah. There was significant MR going all the way up to the posterior wall of the left atrium. And the other important finding in this patient is that he's got right ventricular systolic dysfunction, which will have to be taken into consideration at the end of the procedure.
Okay, so thank you, Dr. Manish. I think now we are ready. We have done 2 punctures. As you will see here, there is 1 puncture, venous puncture on the left groin, through which we have put the pacing lead. This is the balloon pacing lead, and with which we will do the pacing at the time of implantation. On the right groin, we have done a 7 French sheath, as you will see here. This is a 7 French sheath. And now we are ready to start with the septal puncture, which is the most important step in this patient. Give me a 8 French sheath, please. The patient is under general anesthesia, and since we need a continuous TE examination, and the puncture has to be done under TE, so that is why we have the TE here. We are not giving any contrast injection because of 2 reasons. One, that we don't need it, and the second is that the patient is having a creatinine of 1.6 and 1.8. Okay, now we are in good position. Okay, so this is going to be a mid inferior or a mid inferior and a posterior puncture.
Yes, sir, but it's quite close to the aorta.
Yeah, okay.
Yeah, posteriorly.
So I'm going posterior now.
Yeah, so yeah.
It's okay?
Yes, this is posterior.
Yeah, it's posterior now.
Yes, posterior. Inferior also.
It's inferior and posterior.
Yes, yes, sir.
Okay. Show us clearly so that everybody understands.
So indentation, this is away from the aorta here in this view.
Yeah.
And away from the SVC in this view.
Okay. Is it okay now?
Yeah, it looks okay. Yes, it is sufficiently inferior.
Okay, no, I don't want too inferior.
It's not too inferior.
Mid basal, mid.
Slightly below the mid portion.
So I am indenting now.
Yes.
Show the indentation, please.
Seen here in this, in the long bicaval view, and in the this is the aortic valve view. We can see indentation in this also, away from the aortic valve.
I am across now. Okay? Am I across?
Yes, that I'll have to confirm, but indentation is in the right position. It's just indenting. It's not crossed. This is almost mid-septum.
Almost mid-septum.
In superior inferior direction.
Now, is it okay?
Yes,
it's actually going through a very thick part. That is why I'm not able.
Most of his septum is quite thick.
Am I crossed?
Not yet. Yes, yes, now crossed.
You have a new needle? Because sometimes the needle becomes very blunt. So you have to take a new one. Okay, so that, okay, put that one. And we are using the stillet of this puncture needle so that we are able to enter inside.
Here.
Punctured, it's already through.
Septum only. I can't see any shadow in the left.
So, but is it a good site or not?
In this view, it looks okay. I will check in the other view. This looks okay, sir. Looks okay.
Mullins is not, it is so thick, the septum. Mullins is not able to go inside. So now we are dilating the septum. Can you pull the T probe a little bit back? Yeah.
हार्ट का ओरिएंटेशन ऐसा कि इमेज से आई नहीं
So now we are taking the agilis sheath inside if we are able to. Yes, we are. So agilis went in quite easily. Where are you?
So here we are trying to cross the wall
Where,
with the help
please?
of pigtail. And we have crossed the wall, and now we have removed the pigtail and kept the hard wire.
So I need the sheath now. So now we have crossed the mitral valve. So we are going to dilate with a 14 millimeter balloon. 1, 2, 3, 4. Deflate. 1, 2, 3, 4, 5, 6, 7, 8. Why? बाहर पुश कर दो थोड़ी सी. चलो go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Deflate.
Now we are taking the valve to deploy it after the serial balloon dilation of the septum.
Wire holding.
But we were not able to negotiate the wall through this
4, 6,
thick
8.
septum, so we have to dilate it again.
10, 12. सही है? Deflate. Deflate away. Deflate. वायर पुल कर रहा है. मनीष हम आधा सेप्टम में वायर ठीक करो. मैं पुश करता हूँ ना. वायर मैंने पकड़ के रखी थी सब टाइट. वायर पकड़ के.
Even after so many dilations, it was quite difficult to cross this thick, hard septum, and we had to really struggle with it.
So I'll have a question later on that what will you do with that ASD which you created?
So we have already, since the patient has already RV dysfunction, so we have already decided that once after doing this thing, we will check in case there is RV dysfunction, so obviously there is going to be right to left shunt. So we already had an
So
idea.
you will leave it as such.
No,
at
we
least
were already like planning to device close this
okay.
thing.
So you did that later
Yeah,
on.
in the end we did the device closure because we had to create around a 18 ASD for this device.
I was thinking because the balloon is, it was
Yeah.
something like that only.
नहीं अब थोड़ा सा सक्षम नहीं है ये सक्षम है उसी में फंसा हुआ है नहीं नोज बहुत अंदर चल रही है सर नोज तो नहीं नोज तो अंदर जा रही है गोइंग इनटू दैट नहीं
So ultimately we were able to negotiate it.
अब ठीक है 160 का 160 चलो पेशेंट करो नहीं अब कर रहा है
हो गया
अब कर रहा है अब ठीक है चलो ठीक है पेसिंग ऑन हाँ गो अप स्लोली 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 नहीं हाँ, मैं पीछे कर रहा हूँ पीछे कर लिया मैंने हाँ गो अप 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 10 डाउन कर दो हाँ रिफ्लेक्ट फेसिंग ऑफ So valve is okay now.
Valve is okay sir.
एक मल्टीपर्पज Okay, so now we will close the ASD, which has been created with a 18 millimeter balloon. Okay. देखो अब सही है पोजीशन
सर एक मिनट देखा उसको नीचे पुश करके
ठीक So far, everything is fine. So now after the mitral implantation, we have now done the closure of the ASD, which we have created up to 18 millimeters. And that is why it was very important because RV functions were also not very good. So we closed this with a 18 millimeter implanter device. And on the echo, Dr. Manish will give you the final outcomes.
So as we can see here, the valve is well seated and there is no turbulence across the valve, which means that the gradient should not be significant. You can measure it also. Hardly 1 meter per second velocity, which would mean that the mean gradient would be less than 3 or 4. And there is no regurgitation also, no valvular MR, no paravalvular MR. And here is the ASD device, which again is quite stable. There is no residual interatrial communication. So overall, very good result. There is no pericardial effusion also, no other apparent complication.
So looks good. Thank you. Thank you very much for this very complicated case of transcatheter mitral valve and valve implantation. And the procedure is now over. We are going to take the patient out of general anesthesia. So good afternoon, everybody. We are going to present to you a case of.
So,
Summarize the case.
so this TMVR was successful, and since patient was having so much symptoms, we had to go with this TMVR. Surgery was high risk, so patient went for this TMVR. The complication, or you can say the difficulty that we had to deal, was the thick septum. Usually the patients who are post-op, they have thick septums, but in this case it was quite thick, so we had to go for multiple.
So my only thing is let's say you have to do it again. So now you have ASD in place. So it becomes a lot more challenging. I mean, so that's a problem. I mean, you have ASD in place. You have to go again. I mean, you cannot do now further valve in valve procedure. I mean, that becomes because then you have ASD in place. So, but as we saw the procedure, it was necessary because you had a difficult time in negotiating the valve across the septum and to the mitral valve. So I mean, just it was a thought from my side.
Thank you, sir. Thank you.
So it was a fantastic demonstration of something which is unimaginable, or rather it was unimaginable before, and we have not done yet in our hospital percutaneous mitral valve. And Dr. Mukesh Goel, any comment quickly before we go into the next talk regarding because he's a cardiac surgeon, he's doing surgical mitral valve replacement very often, and just a comment from you.
So now basically managing heart valve disease has become a team effort and integrated approach. We have to tailor the treatment and intervention modality as per the requirement of the patient, risk profile, and expected survival and longevity. So that is very important. Like there came a issue of tissue valve or TAVI in a younger patient. What we should remember that the tissue valve, which we claim that it may last 10 to 15 years. So that is true if we are implanting a tissue valve, whether it is a surgical valve or a TAVI valve in a 70-year-old patient. But if the same valve is implanted in a 40-year-old patient, it will degenerate in 4 or 5 years because the metabolism of the body is high in younger age. And so these valves, they last much shorter and lesser in younger patient compared to older patient. So that we have to take into account. Second, if we have to change a TAVI valve to a surgical valve later on, suppose it goes bust in 4 or 5 years, then the mortality with the surgical implantation, which was originally 1%, it becomes 15 to 20% if we have to remove a TAVI valve and put in a surgical valve. So we have to take these things into account, and thank you very much.
So surgeons have a balanced view. So I think we have to move on to this, but I would still say that percutaneous technique is evolving like anything, and nobody wants to have a knife on the chest. So it's always better to do something, but of course the things are evolving, and the same thing which happened with when Andreas Grundzig did the first angioplasty and the first stent by Dr. Ulrich Sigwart. A lot of people might not know that Ulrich Sigwart and Dr. Jacques Paul from France, they did the stent together. But Jacques Paul, nobody knows because he did not publish the data. So let's say what everybody knows, our dear friend, of course. So the same thing happened when we started doing surgery, bypass surgery became at the back foot because of the evolved technique. And a lot of surgeons are doing percutaneous now valve technology. So it's a very interesting and very promising thing, especially in elderly population and those who are frail. So coming on to the next talk, because before we have to go for lunch, Dr. K.K. Pandey is requesting for talk now. So just have a quick 10 minutes talk on diabetic foot. Dr. Pandey, please. So then we'll have lunch and they have a lot of symposium. I would request all of you doctors who are staying here to stay back, because being Sunday, a lot of people are not able to come because it's the last Sunday of the year. And we are approaching 2025 very soon. And we hope that 2025 will be better than 2024. We always feel when the new year comes. Dr. Pandey, we have the slides ready? So he will be talking about diabetic foot, is it? So you know, diabetes causes lot of problems because they got micro circulation problems and arterial problems and diffuse atherosclerosis and that is why this ischemic limb. We have some ulcers and we have a bad supply and those patients will have a difficulty and they will have a diabetes related ulcers or poor sensation. Dr. K.K. Pandey is our colleague in cardiac thoracic surgery, but he's doing mostly thoracic, not cardiac surgery. And he also specialized in peripheral. You don't have the slides now?
No, sir. Actually, internet is not working.
So can you speak without slides? 5 minutes. I'm sorry for that because they said they could not download the slides. You have to be very cautious. Audiovisual people, you have to be very, very cautious in this. You have to have people ready with the slides. Do this again. It's a soft way of is scolding you. Chalo. So he will talk. He's a master, so he can talk without the slides also. Okay. We'll try to download it.
Thanks, Dr. Vivek Gupta, for introducing me. I am very grateful to him for inviting me on a very, very important topic, diabetic foot. Loaded? So anyway, we will start. I think थोड़ा सा हिंदी में बोलता हूँ, लोग पीछे बैठे हैं ना, हैं? शुक्र। हाँ, मैं बाकी स्लाइड्स तो है नहीं, तो मैं एक जनरल बात करता हूँ और डायबिटिक फुट
ये जो सारा फेसबुक लाइव पे रिकॉर्ड होके ये काफी लोगों को पब्लिक में भी दिखाया जाएगा, तो यू कैन टॉक इन लेमन।
हाँ, लेमन लैंग्वेज। तो डायबिटिक फुट ऐसी समस्या है कि हर कोई किसी के घर में, हर एक के घर में कोई ना कोई पीड़ित रहता है डायबिटीज़ से। और मैं इस टॉपिक को बोल रहा हूँ कि लोगों को ये पता नहीं होता, डायबिटीज़ वैसे हर बॉडी के हर ऑर्गन को डैमेज करती है, लेकिन पैर जो है डायबिटिक आदमी के पैर वो दुश्मन है, उसको सबसे पहले अटैक करती है। और बहुत सारे लोग करीब 9 to 10% इंडिया में डायबिटिक फुट के मरीज जो है अपना पैर खो देते हैं। तो आप इस फिगर को याद रखिए कि इसका मतलब ये है कि 100 में से 10 लोग देर सवेर पैर को खो देते हैं, तो इसलिए थोड़ा संभल के रहिए। और डायबिटिक फुट अक्सर बात होती है कि डायबिटिक फुट आखिर होता क्या है? डायबिटिक फुट क्यों बोलते हैं? अगर आपके पैर में दर्द हो रहा हो और जलन के सेंसेशन हो रहे हों, टिंगलिंग जैसे इसको बोलते हैं, टिंगलिंग हो रही हो, तो इसको डायबिटिक फुट बोलते हैं। दूसरा, अगर आपके पैर में फफोले पड़ गए हों, ब्लिस्टर्स इसको बोलते हैं, तो वो डायबिटिक फुट में आता है। आपका चोट लग गई, नीडल चुभ गई अब पैर में और वो घाव भर नहीं रहा है, ड्रेसिंग करे जा रहे हैं, एंटीबायोटिक चल रहा है, तो उसको भी डायबिटिक फुट में लाते हैं। और पैर अगर काला पड़ गया, खाल उसकी रंग बदल रहा है, तो वो भी डायबिटिक फुट में कहलाता है। आप लोगों को बात मेरी समझ में आ रही? पीछे जो लोग बैठे, तो ठीक, तो वो डायबिटिक फुट में आता है। तो आप ध्यान रखिए कि अगर पैर का रंग बदल रहा है, और ऐसे तो उसकी और भी चरम स्टेज है, शार्कोट फुट बोलते हैं, जिसमें शेप उसका बदल जाता है। अब आती है बात कि ये होता क्यों है। काफ़ी लोगों के मन में ये शंका आती है कि डायबिटिक फुट आखिर होता क्यों है। इसका सबसे बड़ा पहला कारण है न्यूरोपैथी। न्यूरोपैथी इसका कारण होता है कि न्यूरोपैथी क्यों इसको प्रॉब्लम करती है कि न्यूरोपैथी में जो पैर की मसल्स हैं वो वीक हो जाती हैं, या समझ लीजिए उनको थोड़ा पैरालिसिस हो जाती, जिससे बोन का जो सपोर्ट है वो ख़त्म हो जाता है और बोन पर प्रेशर आ जाता है बहुत ज़्यादा। और वो प्रेशर इतना ज़्यादा होता है कि वो दबाव बनाता है, जिससे खाल पतली हो जाती है जो उसके दबाव के नीचे, और उसमें घाव बन जाते हैं। दूसरा कारण होता है कि पैर में खुश्की आ जाती है न्यूरोपैथी के, तो खाल जो होती है वो खुश्क हो जाती है, तो क्रैक्स पड़ जाते हैं। क्रैक्स पड़ जाते हैं तो उसमें गड्ढे बन जाएंगे, घाव बन जाएगा जो भरेगा नहीं। तो ये न्यूरोपैथी इसका बहुत बड़ा कारण होता है डायबिटिक फुट में। दूसरा, ब्लड सप्लाई का प्रॉब्लम होता है। ब्लड सप्लाई इसमें कैल्शियम और फैट जो ब्लड का पाइप है पैर में खून जाने वाला, जो ऑक्सीजन वाला खून जाने वाला जो ब्लड पाइप है, उसमें फैट और कैल्शियम डिपॉजिट होता रहता है। तो उससे क्या होता है कि सप्लाई पर असर पड़ता है। तो अगर पैर की सप्लाई कम हो गई तो मांसपेशियों को खून नहीं मिलता है, ऑक्सीजन नहीं मिलती है, तो उनको पैरों में दर्द शुरू हो जाता है। और अगर ये सिचुएशन कंटिन्यू रहती है तो पैर में गैंग्रीन बन जाती है और काला पड़ जाता है पैर। तो अब बात आती है कि इसको हम क्या करें अगर इस तरह की सिचुएशन आती है। तो हमेशा अस्पताल में जाएं, अपने किसी वॉस्कुलर सर्जन से इसका कंसल्ट करें।
Your slides have
yes, आगे कम
clear.
So these are the pictures not taken from any internet or downloaded. These are my patients. You can see how the leg, feet are looking like this. See, all these people are not very, don't think they are uneducated. They are educated people whose feet I am displaying. Okay. See, this is the place you must have seen your relatives or this kind of feet. Indicator. See, this, if this is the feet, it contains pus, definitely. And this was the amputated and non-healing ulcer. The neuropathy I have already explained. So, and this is the blood supply, decreased blood supply, another reason. So what to do? Go to a hospital where vascular surgeon is available, and these investigations are required: X-ray foot, Doppler test, CT angiography, diabetic foot scan. These all things are required to assess the neuropathy. So what is the treatment? If you find is smelling infection, wound very infected, pus containing, first thing is you have to get rid of this infection. You have to repeat a debridement, cleaning in the operation theater, 1 sitting, 2 sitting, 3 sitting until infection is not there. And special medicines are required. Then WAC dressing is also required if the large wound is there and deep wound is there. So we try to save the foot as early as possible. See, this is the patient, came from Assam. He applied, put his near the heater. You know the heater, he put his foot. And then he got the blisters and all this. Self-treated in Assam, and then after 1 month he came to me. See the leg. So we have to do a lot of work for 2-3 months, repeated debridement, cleaning and all this, WAC dressing. And then after later on, pedicle graft was put. Okay, released from here and then put. And increasing the blood supply. Blood supply is also, we have to increase. If you find on angiography, you find blockade. अगर आपको ब्लॉकेड मिल रहा है कि ब्लड पाइप आपका बंद है, तो उसमें एंजियोप्लास्टी, स्टेंटिंग करने की ज़रूरत पड़ती है। लेकिन उसके ब्लड सप्लाई बढ़ाने के भी 3 कारण, 3 रास्ते हैं। एक तो पहला रास्ता तो ये है कि रेगुलर वॉक करिए। अगर रेगुलर वॉक करेंगे तो ब्लड सप्लाई बहुत ज़रूरत होती है। अगर ब्लड सप्लाई कमज़ोर होगी तो आपके अल्सर और ये सब बनने की बड़ी चांसेस हैं। एक ये इंग्लिश में है, संस्कृत में कहावत है, चरतो चरता भागा, यानी जो चलता है उसके साथ भाग्य और संपदा भी चलती है। तो इसको ध्यान रखिए, वॉकिंग सबसे ज़रूरी है डायबिटीज़ में। ये देखिए, ये जांग के पास ये ब्लड पाइप बंद है, तो इसमें एंजियोप्लास्टी, स्टेंटिंग की गई, जिससे खून का सप्लाई बढ़ाई गई। ये बढ़ानी जरूरी ना, ऑक्सीजन अगर नहीं जाएगी तो घाव कभी नहीं भरेगा। तीसरा ये है बाईपास ग्राफ्ट। तो इसमें ब्लड सप्लाई में ये पैरों से लेते हैं इसको नस और इसको यहाँ जोड़ते हैं, तो ये वीनस बाईपास ग्राफ्ट कहलाता है। अगर वो नहीं अवेलेबल है तो ये आर्टिफिशियल ग्राफ्ट लगाने की जरूरत पड़ती है। दूसरा, ये सब ट्रीटमेंट तो है, लेकिन उससे इम्पॉर्टेंट ये है कि प्रिवेंशन इज मोर इम्पॉर्टेंट। तो प्रिवेंशन ज़्यादा इम्पॉर्टेंट है रादर देन ट्रीटमेंट। तो डायबिटीज़ वालों के लिए चप्पल, सैंडल, स्लीपर्स ये पहनना वर्जित है। इसको मत पहना करिए, चप्पल सैंडल डायबिटीज़ वालों के लिए जहर साबित होता है। ये इंसोल आते हैं जिसमें आपको बताया प्रेशर एरियाज होते हैं, इनको डीलोड करना पड़ता है। तो ये इंसोल आते हैं, इसको पैर में डालिए। ये घर में आप इस तरह के क्रॉक्स के आते हैं शूज़, इसको पहना करिए। और बगैर मोजों के कोई जूता मत पहनिए। और नंगे कोई कॉटन सॉक्स आते हैं, सॉफ्ट टिश्यूज, नेवर वियर शूज विदाउट सॉक्स, ये ध्यान रखिए। और नेवर वॉक बेयर फुटेड आइदर इनसाइड द होम और ऑन द ग्रास इन द पार्क। जनरली डायबिटीज मरीजों को पता नहीं क्या होता है कि वो कहते हैं घास में चलो बड़ी ठंड लगेगी, पैर में बड़ी अच्छा लगता है। सबसे बड़ा ट्रिगर पॉइंट वही होता है पैर खोने का, जो घास में चलने की आदत बनाए हुए हैं। और दूसरा, ये हॉट समर्स में लोग मंदिर जाते हैं नंगे पैर, तो कई हमारे पास मरीज आए उनके पैर में ब्लिस्टर्स हो गए। जून के महीने में वो नंगे पैर, लंबा मूर्ति के दूर तक जाने का रास्ता था कॉरिडोर, और वो गर्म उस पर फ्लोर पर चले और उसके बाद वो ब्लिस्टर्स लेकर के आ गए। तो कृपा करके जब मंदिर भी जाएं तो हमेशा सॉक्स पहन के जाएं मंदिर में, गड़बड़ नहीं करें। और 5 से 6 किलोमीटर डेली चलना चाहिए। ये जो मैं प्रेशर की बात कर रहा था, अब आप प्रेशर देखिए, प्रेशर एरियाज कहाँ होते हैं। जो मैंने बताया कि मसल्स जब वीक हो जाती हैं तो ये देखिए, ये हड्डी पर यह प्रेशर आ जाता है, ये कर्वेचर ऐसे लिया, ये डायबिटिक फुट की एनाटॉमी है, तो यहाँ पर प्रेशर आता है। ये पंजे नुमा ऐसे आप देखिएगा डायबिटीज़ में जो उंगलियाँ यूँ पड़ती हैं, टोस जो है यूँ पड़ते हैं रादर देन स्ट्रेट, तो इस पर प्रेशर आता है। तो ये प्रेशर एरिया है, ये प्रेशर एरिया और ये प्रेशर एरिया है। और ऊपर से सप्लाई का ये तो प्रॉब्लम होती ही है। तो ये जो प्रेशर एरियाज का अगर आप केयर नहीं करेंगे तो आप प्रॉब्लम में फंसेंगे। ये देखिए, ये प्रेशर एरियाज हैं, ये देखिए नंगे पैर चलने से और केयर नहीं करने से ये प्रेशर एरियाज बन गए। ये प्रेशर एरिया, ये प्रेशर एरिया, ये देखिए घाव बन गया। और ये गैंग्रीन देख रहे हैं ना। तो आप एक तो डायबिटीज़ में वेट मत इंक्रीज करिए और ब्लड शुगर हमने कंट्रोल में रखिए। देखिए, अगर अनकंट्रोल्ड शुगर रहेगी तो कुछ भी करें तो डायबिटिक फुट होने के काफ़ी चांस रहते हैं। और ट्रीटमेंट फेल क्यों हो जाता है? अगर डायबिटीज़ का मरीज सिगरेट, बीड़ी, खैनी, चैनी, पान, गुटखा, जर्दा ये सब अगर खाएगा तो कुछ भी करिए, ट्रीटमेंट सब फेल हो जाता है। और दूसरा, डिसिप्लिन लाइफ होनी चाहिए, वॉक करें डेली, अपना ब्लड शुगर, कोलेस्ट्रॉल, वेट सब कंट्रोल करें, तो आपके पैर बचने की संभावना रहेगी। अन्यथा पैर खोने के अलावा, जैसे मैंने बताया कि 100 में से 10 लोग पैर खोते हैं, तो फिर इसी कैटेगरी में आप पहुंच जाएंगे। थैंक यू।
थैंक यू वेरी मच डॉक्टर पांडे फॉर नाइस। थोड़ा सा मैं गुजारिश करूंगा अगली बार अच्छे अच्छे फोटो दिखाइए। बट अनफैक्ट द पिक्चर्स आर दे आर नॉट सो आई सूदिंग, बट ऑफ कोर्स दैट इज द फैक्ट। सो थैंक यू वेरी मच फॉर गिविंग दिस इनसाइट। बट वेट भी कम करना है, खाना भी कम खाना है, शुगर भी कंट्रोल करना है, 5 किलोमीटर रोज चलना है। 5 किलोमीटर आप चलते हैं? अच्छा, पूरा डॉक्टर एस के गुप्ता चलते ही हमको पता है, बट वी डोंट वॉक सो मच। बट so it's not easy to have that life, so that not to have diabetic foot. But thank you very much. This was a nice symposium. And how many people are still with the Zoom? Doctor, we just say goodbye to them. Who are the people available on the? Yeah, Dr. Mansoor is still there. Thank you very much for being with us. We have to break for the lunch. Matlab break means lunch break. No, we are not breaking ourselves. We have to break for lunch. But maybe a final comment from your side. Regarding the diabetic foot, I mean, we all are treating diabetes day, night, and Dr. Mansoor, just for the people who have come late, is a very senior cardiologist from Karachi, our dear friend, because I have been there multiple times because of his invitation. He's a very thorough gentleman and a very educated person who knows all aspect of cardiology. Very quick about the diabetic foot, what you heard from Dr. K.K. Pandey.
I think I have always complained to diabetics. Sorry, is it me?
Yeah, you're perfectly audible.
Yeah, I've always complained to diabetics that whenever these patients come in, they have an ulcer, they keep putting bandages, and then finally they chop the foot off. And I asked them, please, routinely, why not do a Doppler or a Doppler flow study on their legs as a routine?
Routine
Despite all
Doppler,
that,
yes.
I think it's such a big problem that we have a massive, big organization here for diabetic foot all over the country. And they're very eminent people and they look after feet very well. But at the same time, I still insist that majority still do not do Doppler. They only see those patients once the ulcers have come up, once they refuse to heal, once gangrene develops. So if they actually do a Doppler, if there is a blockage, you just do an angioplasty there. And even if it closes down, most of the time the ulcer will heal, the wound will heal, and at least amputation will be saved.
Below
So
knee
I
angioplasty,
insist
yes.
that we should all do that.
Thank you for this comment, because peripheral angioplasty is a very important aspect of reducing the less leg being taken away for the amputation, and therefore you may have less ischemia. Dr. Abdul Rashid Khan is there, I just joined in. Very quick comment of 1 minute. Dr. Abdul Rashid Khan?
Can you hear me?
Yeah, quickly, yes.
Actually, I'm totally convinced with the lecture that diabetes should be taken very seriously. And if there anybody is developing any diabetic foot, it must be treated in very early stage. Otherwise, there are always chances of losing the feet or sometimes even the leg is imminent. So diabetes should not be taken lightly, and it should be controlled accordingly with the multiple drug therapy. Thank you.
Okay, so thank you both of the
Yeah,
panelists.
one
from
more thing, even after
Yeah, Dr.
amputation.
Vimal Mehta. Yeah.
Sorry, sir. I mean, one comment. Even after amputation, I mean, even somebody has, they have a demarcation line and you decide to amputate, even then vascular supply restoration by angioplasty or whatever means important, because otherwise your amputated stump is never going to heal, and you will continue to, day may come that you will have to amputate, even higher up. Let's say you do below knee and, your vascular. So that's also very important point to note. Thank you.
I think I may request Dr. S.K. Gupta to please join and hand over the mementos to the speakers of the previous session, and then we'll have a lunch. Please, Dr. S. Gupta, please. So we'll have a lunch break, but I want Dr. Mansoor, if you can come back after half an hour. It will be your ICR meeting, Indo-Pakistan, Indo-European.
Yeah, if you don't mind, can you give me 1 hour? I see people are visiting me in
Your comments and Dr. Khan comments are very valuable. And so I thank panelists Dr. Vimal Mehta, Dr. Vanda Bagga, and and all the speakers for this session. Dr. Kundu was here, but Dr. Podar was here, but they didn't come in the front. Doesn't matter. We have a half an hour break only. 2:45 we will have a scientific session starting, because we have a lot of lectures. Give you the insight of the lectures we have. Dr. P.C. Rath will be speaking, before Dr. S.K. Gupta, Dr. M.K. Das from Calcutta, Dr. Anil Dhal, Dr. Carlo Di Mario, Dr. Samir Kubba, Dr. Siddhant Rehan, Dr. Deepak Jain from Germany, Dr. P.C. Rath, myself, Sigvert, Dr. Colombo, Dr. Egypt, Dr. Gada, Kazamil, the Dr. Sievert from Germany, Dr. P.K. Ashokan and Amit Munjal. So many lectures are still left out, and we have to finish before 6:30. So I will request that everybody should have quick lunch, and 2:45 we have to start the talks with Dr. S.K. Gupta, and the audiovisual people should be ready with the slides, and I would request Dr. Deepti and many other people who have presented to stay back for the whole day. Today is Sunday, so please have a quick lunch and come back. And Dr. Podar, please go ahead with the lunch and come back. You have to chair the next session. Thank you.
Recording stopped.